Good morning, all. So to kick off today's session, we are pleased to invite our first speaker, Professor C.F. Otieno. Professor Otieno is an Associate Dean, Faculty of Health Sciences, University of Nairobi, Kenya. The topic for his lecture is Diabetes mellitus and Cancer Risk Association. Welcome, Professor Otieno.
Thank you for the kind introduction. By training, I'm a physician, and we are starting a bit late, and try and condense the slide, and then let's try and spare some time for discussions and input. So my brief was Diabetes and Cancer Risk Associations, and I will give you some epidemiologic and care perspectives. By no means it is a very, very broad topic, and I will try as much as possible to keep the discussions or the presentations fairly broad, granular in certain areas, and I've picked a few important cancers that relate very, very closely to diabetes for our discussion and commentaries later. So that's really the outline that we are going to follow: diabetes, cancer incidence, epidemiology, and some prognostics, diabetes, cancer, and obesity, some biologic links, then of course with specifics relating to pancreatic, breast, and other select cancers. Then of course I have looked at metformin as a major risk modifier in type 2 diabetes, and of course some questions to think about at the end of it all. Thus, as an introduction, diabetes is not uncommon. For all of us, you remember, if you said common, then more than 50%. If it is less, then it is uncommon, not uncommon, but it's not rare. So a bit of semantics, but you get the message. It is a risk factor for certain cancers, literally all cancers except prostate for some reasons that we might just refer to, but mainly pancreatic, liver, colorectal, breast, and of course endometrial cancers. Then the causal consequence relationship, the times when we use steroids in patients that are predisposed to cancer, to diabetes, and cancer patients who receive treatment may actually tilt towards or become diabetics now with cancers, so that the treatment unmasks the previously unknown risk in those patients. But it is now known that it's now known that indeed the diabetes enhances risk of many cancers, and we've picked just a few to talk about. And the care requirements is multidisciplinary, that we all are. Busy slide, as it were, but that just tells you, if you look at the right side of the slide, the message is that most of the diabetes and the associations with oral, gastric, colorectal, hepatocellular, you can see on the right-hand side of that middle line, that means enhanced occurrence. And most of them, as you can see, the ACE enhanced occurrence of cancers in diabetes. Again, that is a New Zealand study. If you look at the color scheme, the green have diabetes, and those without diabetes have the other color. And you can see the patients without diabetes have more prostate cancer, but then the other cancers, diabetes seems to enhance the occurrence of the cancers. Largely the same, but looking at the age standardized ratios, again, that's a New Zealand study. Like I've said, type 2 diabetes is associated with some tumors a bit much more. Twofold increase, especially pancreatic cancer, hepatocellular cancer, and endometrial cancer. The cancers have certain predispositions that make them a bit more common in type 2 diabetes. Then, of course, the colorectal, colonic and rectal cancers, bladder, breast, and bladder, sorry for the typo. And then, of course, the other situations, kidney, non-Hodgkin's lymphomas, and no specific association has been adduced. Again, that is still showing the same. Bladder, breast, colorectal, pancreatic, prostate, stomach, not that much. But because of the shared risk over age and diabetes and cancers, then you may find certain coincidental associations, but of course diabetes enhances for reasons that we are going to talk about shortly. The risk factors, as we know them, that tend to be much more common is overweight and inactive lifestyles, then of course older age and cigarette smoking. So your patients that smoke cigarettes, your patients who are overweight, and this varies from environment to environment, but about 55 to 65% of type 2 diabetics have obesity, insulin resistance association, and that constitutes the more reversible component of type 2 diabetes. The others that may not have that potential for reversibility are also known in type 2 diabetes, but they also have their own unique predispositions. So that the mechanisms lies within the insulin growth factor, and the signaling mechanisms that we may just look at very, very briefly after. But the inflammatory milieu or environment of obese type 2 is much more driving than any other. And of course, that has been shown even in basic science. And that is largely the pathway, if you look at it, that there are some hormonal predisposing or enhancement in both pancreatic and breast cancers, and the mechanisms have been shown as indicated. At a molecular level or a mechanistic level, then of course the inflammatory situation gives us reactive oxygen series, excess reactive oxygen series because of the hyperglycemia. Then of course the critical macromolecules are consumed there, the chronic inflammatory state I've talked about, and then impaired repair mechanisms. In diabetes, a part of the process, people who don't develop cancers have this unique mechanism of epithelial to mesenchymal transitions. For those who read about diabetic nephropathy, even heart and other related end-organ damage, you know how cell transformation occurs from the functional one to the fibrous forming cells within that chronic inflammatory process. And patients who develop cancers also in the process get tilted towards carcinogenesis. So that you get an initial DNA damage from that reactive oxygen series, then poor clearance, and then of course the chronicity, persistence now leads to the loss of cell growth control, and the neogenesis continues with neoplastic changes in certain individuals. And this is driven again at molecular level through that cytokine rapporteur, interleukin-6, and tumor necrosis factor alpha. Again, that is a potential mechanistic pathway, the hyperinsulinemia. Insulin has that growth stimulator capacity, and when there is lack of cell growth control in certain diabetics, then that becomes a driving factor. And the intestinal, we shall look at the predisposing factors, the breast, and of course the pancreatic. But that framework of cellular function gives you a rough idea: type 2 diabetes, the obesity, and then inflammatory process with the inflammatory cytokines, then of course driven distally by the insulin growth factor, dyslipidemia, and this is a driver within the colorectal environment or structures, and that is a critical factor in tumor cell growth. And again, these are just different versions of the same inflammation in obesity, the type 2 diabetes, the insulin growth factor, insulin and its growth factor action axis. Then, of course, distally, you get altered function in terms of clearance of the abnormal cells, and in some individuals, they become neoplastic. That association still remains. Now you can see ovarian, query, prostate, because of the endocrine rapporteur, the testosterone, which is reduced in obese type 2 diabetics, then testosterone is a driver of prostate cancer, and you can see that inverse association. But the rest of the tumors are increased in type 2 diabetes. And you can see the factor of increase if you look at the relative risk increment and the confidence intervals. Depending on the size of the confidence interval, the width, that risk is higher when the confidence interval is narrow. Now, picking specifically the pancreatic, the incidence, as we said, is about twice in patients with diabetes. And it is important to remember that the pancreatic cancer is quite often associated with new onset diabetes in patients, especially the old ones after 55 that present with type 2 diabetes. And as a clinician, you want to look for other related obstructive phenomena in such patients. And the weight loss may be common, but not necessarily related to type 2 diabetes, but the ongoing malignancy. And indeed, the studies that I've quoted there confirm, or not really confirm, but attest to that association. And this is a predictor, like 5 most important features that were associated with pancreatic malignancy are the A1C, high A1C, hyperlipidemia, especially the LDL cholesterol, anti-diabetic drug use, especially the sulfonylureas, and of course, this just goes back to this, but this was a machine learning kind of, you feed in. If you give in garbage, you get garbage out. If you give in the symptoms that and signs that you get, lab features, that's what now enhances. That just shows similarities in that kind of patient series. And the advanced glycation end products and receptors for advanced in carcinogenesis, that just shows you distally hypoxia drives inflammation, apoptosis, and the autophagy is reduced in such patients, and that's also augmenting poor immune surveillance in such patients. And the pancreatic one, from where it sits, there is that the microbe proposition, and of course the chemical component. So the microbe are those risks from the pathological, the pathogens, and they share significant association with colorectal, and this relates to what we call the intestinal microbiome. And that now brings that into very, very close perspective, so that the gut microbiome, and then you notice the oral microbiome. This is selected by diet and the things we eat and how we prepare them. And that carries some risk, but this is work in progress. Of course, the Helicobacter pylori is part of the proposition, but suffice it to say that therefore, as a selecting mechanism for the oral and gut microbiome, may predispose patients over time to the carcinogenesis. And of course, that eventually now causes what we call the reduction oxidation imbalance, dysregulation of cell cycle, reduced apoptosis, and regional or local immunosuppression. The liver one is interesting because the non-alcoholic steatohepatitis is a feature of insulin resistance in type 2 diabetes. And hepatitis C is directly a cause of type 2 diabetes. However, it's not a very common condition. Hepatitis B, epidemiologically, even at cellular level, has definite association, but they are not that common. In fact, hepatitis B has been reduced by immunization. So then hepatocellular carcinoma comes as a consequence of non-alcoholic steatohepatitis, and progressively from fatty liver to fibrosis and then carcinogenesis. And that is the link. So then it is thought that in the West, the now driving force of hepatocellular carcinoma is that fatty liver in patients who have diabetes. However, this has not been seen in the developed world that much, where we have hepatitis B and hepatitis C, and then and many other predisposing factors. Colorectal, we've talked about aging, obesity, sedentary lifestyle, then of course, low fiber diet. The low income countries have had high fiber diet, but with the time of imbibing what they call development, people take less refined diet, much more refined diet, and less of the vegetables that they used to take. And the vegetables as fiber have been very, very important in selecting the gut microbiome. And high fiber diet is associated with lower colorectal cancers. And patients who have low fiber diet, therefore, have a high incidence of colorectal cancer. So you can see that link. And when we advise our patients on the kind of diet, we need to enhance fiber content as a subsequent or a consequent modifier of carcinogenesis or cancer development in colorectal CA. The breast, again, is an interesting area. There is breast diabetes-associated breast cancer, because breast being largely fatty tissue, and there may be very unique associations along the same lines that we've talked about. This occurs after menopause, after 50 years of age, and the associations are also having a lot of scientific details, and that outline from dyslipidemia, insulinemia, and of course hyperglycemia, all contributing towards, especially in poorly controlled diabetics, this triple negative breast cancers that are neither estrogen nor progesterone nor epithelial growth factor marker positives, and they are very poor prognosis. So the cancers in type 2 diabetes enhances, the diabetes in cancers enhance mortality and poor response. So that is important. When you have a patient who has a cancer and is diabetic, the outcomes are very, very poor. Endometrial, the same, again, unique in type 2 diabetes for reasons that overlap, but the endometrial one is unique in its own right, and the reasons we may not go into at this, because that falls within the purview of oncologists and gynecology. The time series is very, very critical, but I'm introducing the role of metformin in this group of patients. Metformin has a unique way of acting and modifies the carcinogenesis in such patients. And this is trying to introduce the time series over time and in patients who are diabetics and receive metformin, and what is the consequence. This is mechanistic, that metformin would modify both energetics and cellular growth in patients as a way of action. And the same metformin has anti-inflammatory and subtle immunomodulatory effects. And that, of course, if you now link with what we talked about, inflammation and a poor immune surveillance in diabetics, then you can actually see metformin as an effect modifier in the carcinogenesis process. And that's just another way of putting across that metformin action distally will affect cell growth, autophagy, and then, of course, neogenesis and cell cycles. Very critical there is the P53 protein, the protein that is involved in the immune surveillance and potential for carcinogenesis. Again, that is how would metformin therefore act? To modulate P53 and therefore cell growth, and then, of course, the oncogenic protein and the potential for that. But you can see the inhibitory effect on that, and then, of course, the energy dynamics of cells for their growth and development. So therefore, the overall consequence in that study, where meta-analysis of multiple studies showed relative risk reduction of up to 39% for the development of cancer in patients who are taking metformin. The duration was not quite clear. The age, this was a composite kind of analysis, so the age differentials or the age bands were not particularly brought out. Then, of course, put in different ways that the overall for type 2 diabetic patients who are ever versus never metformin users, there was significant risk reduction of up to about 30, from 35% to about 20, from 24% to about 35% risk reduction. And it indicated that indeed metformin may be an independent protective factor for cancer risk in type 2 diabetes. And this is another way of putting it, that there is risk reduction, summary relative risk reduction. You can see how broad the confidence interval is. So depending on which cancer one is looking at, and the age factor. That also brings out the same message. And therefore, the factors that are already in summary, we are talking about factors that influence the choice of cancer therapy in patients with diabetes, include the adequacy of metabolic control, and patients who are poorly controlled respond poorly. And then, of course, the anti-cancer treatment is also very, very important, because others are diabetogenic, others are not. So that determines in that multidisciplinary approach, you need to have a discussion. So my last slide is posing questions for us to think about. That is, cancer screening required for patients with pre-existing diabetes? Would it be cost-effective or cost-beneficial if we decided to screen for cancers? But which ones? Especially the ones that I have emphasized: pancreatic, colorectal, breast, endometrial, and how can outcomes be mitigated? We have said that patients who have diabetes and cancer do poorly, or have cancer and diabetes do poorly, depending on the situation at hand. How can we maximize outcomes? Then cancer screening tests, and of course the educational intervention. I've already mentioned the issues of diet, fiber, and of course for diabetologists, this that you do to your patients routinely. What are you going to, the screening tests have proven benefit, but especially breast and mammograms, colonoscopies, and then the gynae in patients who are at risk. But what is the threshold for the screening tests? Then which cancer are more likely to be mitigated by these screening tests? Of course, we say breast, colon, but what is the threshold? You say 40 years, 55 years, 60 years, or what is our threshold? It's more research that will advise. Then, of course, should all patients with type 2 diabetes receive metformin as part of their treatment because of its mitigatory effect? That's very, very controversial, and we use metformin for its metabolic benefits. But what about the speculation of the cancers? That is far-fetched as of now, but the evidence that we have adduced that it mitigates the development of cancer may make one think that indeed patients who take metformin for long may have some mitigatory effects in the development of cancers. And for all your attention, I would say thank you.
Thank you so much, Professor Otieno, for such a profound lecture. Should you allow, like to welcome one or two questions from the attendees, if there are any?
Yes, thank you, Professor, for the wonderful presentation. My name is Joseph Baluku. I'm a physician from Uganda. I liked the idea of metformin really attenuating cancer risk because of the anti-inflammatory and immunomodulatory effects. And therefore, I'm wondering, by extension, would that apply to statins? Because we know statins are generally recommended in people with type 2 diabetes for so many other reasons. So is that benefit seen also with statins? And would there be a synergistic effect if you have both metformin and statins in the same individual? Thank you.
Metformin, yes. Statins are not very universal. Yes, very anti-inflammatory, but for who? There's a level, depending on your statin strategy, high intensity, low intensity, intermediate intensity, now in the realms of the cardiologists. I don't know how often now people develop statin-related intolerance to whatever dose one is using. So statins have issues at that level, mitigatory on the inflammatory domains, but the tolerability may therefore bring into perspective how long, which strategy, high dose, intermediate, high intensity, intermediate, or low intensity, so that has not been in my own review did not particularly feature prominently as a way of mitigating malignancy, evolution of malignancies. But from the scientific perspective, molecular biology, it makes a lot of sense. However, at therapeutic levels, it may bring certain questions into perspective. And the strategies, therefore, and new strategies that are coming, which are not particularly anti-inflammatory or pleiotropic as the statins, then one may start asking, are we pushing it too far? But that's really the background. That would inform the use of or combined use of metformin. But metformin is a wonder drug from the way it works, and is it who benefits? This is the other point. Who is it? Time dependent or idiosyncratic, or what is it? And of all the consequences, are there people who may, by nature, because if you look at the drug transport of metformin across the cell membrane, there may be mechanisms that may be idiosyncratic. If you look at that molecular basis at the organic cation transporter protein, and take a step backwards and actually look at it from the tolerability, which is idiosyncratic, and therefore the way it works and the way it affects people, then that might also bring into perspective other questions. Indeed, when the tolerability comes, then it alters the intestinal microbiome very, very significantly. So we are suggesting that may be direct, but at the other end, especially in colorectal and therefore pancreatic, altered microbiome may also be a mechanism. But this is a whole world ahead of us, and I can see many youths that can take it up at epidemiologic level and at molecular level. Thank you. We can take to save time.
Yeah, we can just welcome last two questions and answer.
Well, thank you. Thank you, Professor Otieno, for a very interesting talk. My name is Lucy. I'm a diabetes researcher in Tanzania. I have several questions. I'll ask a few. The first one is on the risk factor for cancer in diabetes patients. I'm curious to know if at all the polygenetic risk scores that have been developed in diabetes could be used to assess the risk of cancer in these patients. And again, there's a lot of theories about lean diabetes in Africa. And of course, we see a lot of patients with diabetes that are not obese. So is the risk the same in this group, or is the risk a little bit diminished because we have less obesity in certain communities? And my third question is there a link between age of onset of diabetes and development of the cancer risk in these patients? And lastly, what is the protective effect of metformin in combination with sulfonylureas? Because it's a bit contradictory for these patients, since they also use the two medications in duo. Thank you.
Multiple questions. I'll give you very short answers. One, diabetes is very heterogeneous, and I started off with that heterogeneity in terms of body mass index. Then you can also define heterogeneity from the age of onset. And this, I said, is a risk modifier. The younger you are, the less likely, but again, the longer you have diabetes as you age, then the risk of having those malignancies also occur. and especially this affects more of colorectal and breast. The late onset diabetes is more likely to be associated with the pancreatic. So age is a risk modifier. The heterogeneity of diabetes exists, but the obese type is more likely to have, especially aging is associated with obesity. Then sulfonylurea, metformin, all these meta-analyses have been done with both treatments combined. So you can see teasing them out becomes a bit of a problem. The lean diabetic only has more hyperglycemia, but there's also, depending, you need to characterize your patient much more, because there is metabolically obese, but they are thin in diabetes. But there are also people who are both obese by body mass index and metabolically not hyperlipidemic. So the heterogeneity is a factor, but the meta-analysis did not tease out who. But age is effect modifier. Metformin use over time is mitigating.
Thank you, Doctor. Allow me please to ask my question in French, because I'm from DRC. Alors, c'est Dr Otenga de l'hôpital général de Kinshasa. Merci beaucoup pour ce brillant exposé. Ma question se veut un peu pratico-pratique, parce que l'objectif ici, en fait, c'est de prendre en charge le diabète dans un contexte de ressources limitées. Alors, on est en face de risques.
Where's my Cameroonian friend who knows both? Okay.
Je disais que l'objectif, en fait, c'est de prendre en charge les patients dans un contexte de ressources limitées. Alors, ma préoccupation, c'est que le cancer, je prends un cas spécifique, par exemple, le cancer du pancréas, peut entraîner le diabète de type 2, et je pense qu'inversement, le diabète de type 2 peut entraîner le cancer. Alors, dans l'un comme dans l'autre cas, comment est-ce qu'on peut faire le diagnostic? Et surtout, comment est-ce qu'on peut prévenir? Parce que c'est ça le plus important d'après moi et d'après tout ce que j'ai fait comme étude avec la bourse Merck Foundation, parce qu'on vise beaucoup plus la prévention dans les pays à ressources limitées. Et c'est pareil aussi avec les hépatites, parce que j'ai eu personnellement beaucoup de cas. Bon, je peux être plus précis avec 4 cas depuis que j'ai eu cette formation, où j'ai eu des hépatites qui ont induit un diabète et inversement aussi. Donc, comment est-ce qu'on peut, de manière pratique, de par votre expérience, prévenir ces corrélations et surtout comment les prendre en charge? Je pense que je peux ajouter une troisième question, une dernière, c'est en rapport avec l'utilisation de la metformine. Alors, en cas, par exemple, d'insuffisance rénale, on sait évaluer la fonction rénale et savoir quel est le seuil ou la dose de metformine qu'on peut donner. Mais on ne sait pas évaluer cela en cas de problème hépatique. Alors, comment est-ce qu'on peut concrètement le faire? Merci.
Can summarize it in English? And I will summarize the answer.
Okay. I think from
Good morning. Is asking in limited resources, as we were taught with Merck programs, diabetes. In patients with we know that diabetes induce cancer and pancreatic cancer and vice versa. They wanted to know, with limited resources, what do you suggest for such countries, or because prevention is better than cure? So what is the main guideline for that? Then secondly, it was asking about in terms of using metformin, and with renal impairment, there is a threshold where you cannot use metformin. and what to do. We know about the renal impairment, but we don't know with hepatic impairment. So we wanted to ask about.
Thank you. We shall still use metformin for glucose control. The extra benefits in mitigating the evolution of cancer is an extra benefit that we cannot quantify for various forms of cancers. But for all the benefits of metformin in managing type 2 diabetes, use it because it lowers glucose. You may get that added benefit of mitigating the evolution of cancer. We still want to approach it with that perspective. That's why I'm asking who and for what cancer. So we shall not approach metformin from a cancer mitigating perspective until there is sufficient data in well-designed studies for that purpose. But of course, real-world studies are saying, like food, if you eat this, you'll get energy, but also benefit from the other. SGLT2 inhibitors, if you use it for sugar lowering, yes, but you'll also get cardiovascular and then benefits or cardiorenal benefits. Then people have gone ahead to design studies to see how you would use those medications for that particular benefit. Similarly, metformin, there have been attempts to use it for mitigating cancer directly, but you need huge dosages unless you get now molecular mimics that now capitalize on the cancer mitigating mechanisms of this drug to produce metformin-like medications with the benefits of metformin enhanced for malignancy. But as of now, use metformin for sugar control purposes with the caveats as required. But remember that there are other benefits and you cannot maximize on because you don't know the dose requirements and duration of their use. Thank you.
Thank you so much, Professor Otieno. As all our delegates know here, we are already short of time. You have another question? Okay, we'll take one final question. Professor Otieno, you can be seated there. You can be seated there. We'll pass the microphone over there. Yeah.
Bonjour tout le monde. En fait, c'est pour revenir sur la question de monsieur tout à l'heure parce qu'on n'a pas eu la réponse. On n'a pas eu de réponse par rapport au diabète associé à un cancer du pancréas. Le plus souvent, le diabète est secondaire au cancer. Et dans ce cas, est-ce qu'on a le droit de parler de diabète de type 2? Parce que connaissant le mécanisme physiopathologique du diabète de type 2, c'est le plus souvent une insulinorésistance. Et là, quand le diabète est secondaire au cancer, c'est plutôt un défaut de sécrétion d'insuline par défaillance des cellules bêta. Et dans ce cas, donc, on n'a pas de diabète de type 2, mais plutôt un diabète secondaire au cancer du pancréas. Et dans ce cas, je voudrais savoir quel est le traitement approprié. Est-ce que c'est le metformine qu'il faudra donner? Parce que metformine sensibilise au niveau périphérique pour l'utilisation du glucose. Et comme là, c'est pas un problème d'insulinorésistance, mais plutôt défaut de sécrétion d'insuline, est-ce qu'on doit donner metformine, surtout que metformine est suspecté comme étant pouvant entraîner un cancer. Il y a des idées allant dans ce sens. L'autre question, c'est par rapport au cancer du foie. Moi, ce que j'ai vu dans mes pratiques, c'est plutôt une hypoglycémie sévère avec les hépatocarcinomes. Donc, je me demande comment est-ce qu'on peut imputer un diabète à un hépatocarcinome. Si vous pouvez m'aider.
So, the first one, in short, she's asking about, we know that type 2 diabetes is insulin resistance, but in the case of pancreatic cancer inducing diabetes, is it advisable? What's the real treatment? Should we still give metformin in that case? Because we know it's a secondary diabetes induced by cancer. So is it still the same treatment with metformin?
We shall use the appropriate sugar lowering mechanism when you get to that situation. As the evidence stands, we may not use in patients who already have cancers. We may not use metformin with the hope that we are controlling that cancer. We use appropriate sugar lowering mechanisms. If it requires the smallest dose of insulin, let's use it. Even when insulin has a potential for enhancing growth in a short time, it doesn't. If anything, it's much more easy to regulate in such patients.
Pardon, tu peux répéter ta deuxième question, s'il te plaît? La deuxième question. Mm-hmm. Okay, she's talking about the hepatocarcinoma-induced hypoglycemia. And in your presentation, you were talking about hyperglycemia, so she wanted some clarification about that.
Hypoglycemia occurs when you see it in patients with diabetes. Primarily, think renal, think adrenal, think liver, and feeding. At that time, the orals are a bit dangerous. In fact, insulin is the easier agent to regulate under those circumstances, because you cannot now control the oral agents in terms of dosages. Insulin is the easiest in acute setting to manage potential for hypoglycemia in those agents, whether it is hepatocellular, adrenal, renal, or any other. Thank you.
Thank you so much, Professor. Now, I would like to call upon our second presenter of today's session, Professor Dr. Tom Devasia. Professor Tom Devasia is a professor in the unit head Department of Cardiology, Kasuba Medical College and Hospital, Manipal Academy of Higher Education, India. Welcome, Professor.
Good morning, all, and warm regards from the temple town of Udupi and University Village of Manipal in south of India. So my topic is cancer as a comorbidity in heart failure. Heart failure, the definition we all have been reading for many years, and the clinical image that comes to our mind is that of a patient with raised jugular venous pulse pressure, pedal edema, leg swelling, abdominal distension, breathlessness, exercise intolerance, and crepitations on the chest. Coming to the cancer and heart failure, worldwide, there are a large number of patients who suffer from heart failure and a large number of patients who suffer from cancer. There are different stages of heart failure. We divide them as stage A, B, C, and D. A means at risk for heart failure. We have the classical risk factors of diabetes, hypertension, obesity, and in addition, we also have an exposure to cardiotoxic agents, especially cancer drugs, that makes the patient at risk for heart failure. Stage B of heart failure is patient has no symptoms, no signs, but the echocardiography will be abnormal, like, for example, left ventricular dysfunction or left ventricular hypertrophy. And if you check the blood, there will be abnormal brain natriuretic peptide levels. In stage C, that is what we all see in our clinics. The patient has symptomatic heart failure, what we described and learned during our undergraduate years. There are symptoms and signs of heart failure. And when they have recurrent hospitalizations and goes down a spiral, which ends eventually in death, and management of heart failure with guideline-directed medical therapy becomes difficult, we call them stage D of heart failure, and these kind of patient may need additional therapy like a device, like, for example, a cardiac resynchronization therapy, or sometimes a left ventricular assist device, or at times even a heart transplantation. This is the chart that says that the field of cardiology and oncology, cardio-oncology, is quite important in the present world because there are a lot of cancer survivors, and the cancer therapy by themselves have advanced because of either one or a combination of chemotherapy, radiotherapy, and immunotherapy. So patients with heart failure, 1/3 of them dies of a non-cardiovascular death, and this is 1/3 of them dies because of cancer. So we know that there is a large number of patients with heart failure who die from non-cardiovascular cause like cancer. Cancer and cardiovascular disease, they have a bidirectional relationship. We know that inflammatory biomarkers like ST2 and MPO can cause inflammation, and the cardiac biomarkers like troponin and NT-proBNP will be abnormal in cases of heart failure or cardiovascular disease, and other inflammatory mediators are involved in cancer biomarkers. There can be quite an interrelationship between these two groups. The tumor by itself can cause damage to the myocardium directly or indirectly, and some of the heart failure patients may be at increased risk of cancer as well. So how can cancer lead to heart failure? There are many mechanisms, and the mechanisms would be them having a common risk factor like smoking, advanced age, diabetes, obesity, and genetic predisposition. Also, anti-cancer therapy by themselves can cause heart failure and cachexia. Chronic inflammation, metabolic remodeling, angiogenesis, and clonal hematopoiesis can cause quite an interplay between cancer and heart disease. Cancer cachexia by itself can promote atrophy of the heart. They can sometimes, the cancer cells can secrete some factors commonly called secretomes, and they promote atrophy of the cardiomyocyte. Also, the cancer cells can mediate systemic and metabolic alterations, and this will impair the function of the cardiomyocyte. And sometimes alterations in metabolic fueling of the heart, as well as metabolic intermediates, can cause altered gene expression and protein function, leading to abnormal remodeling of the cardiomyocyte. A few examples of anti-cancer drugs that can affect the cardiovascular system. We know the age-old anthracycline, doxorubicin, that can cause left ventricular systolic dysfunction. some myocardial ischemia and thromboembolism. Even the newer drugs, the tyrosine kinase inhibitor that will be ending with MAB and NIB, and the anti-angiogenic therapy of VEGF inhibitor, all these can cause hypertension, ECG changes including bradycardia, QT prolongation, contractile abnormality, and thromboembolism along with coronary artery disease. The immune checkpoint inhibitors like nivolumab and ipilimumab can cause myocarditis and pericarditis and can affect the heart. So in general, all these anti-cancer therapy drugs can cause a variable incidence of at least 1 to 5% incidence of left ventricular dysfunction and heart failure through the various mechanisms. And so it is very important that we keep an eye on the cardiovascular status of these patients who are on treatment with these drugs, or consider alternate therapy in patients who are at risk of developing heart failure. So if you look at the cardiac adverse effects related to the anti-cancer drugs, they can have apoptosis or self-programmed cell death and fibrosis as in anthracyclines. There can be metabolic abnormality with mitochondrial dysfunction. There can be ischemic heart disease and coronary heart disease, rapid progression of the plaque, and myocardial infarction. There can be thrombosis. There can be ECG abnormalities, including QT prolongation and bradycardia. There can be abnormal contractility related to nitric oxide signaling abnormality. And there can also be hypertension, as in the case of tyrosine kinase inhibitor and monoclonal antibody use. So how heart failure can lead to cancer? As I already mentioned, there are some common risk factors. And there has been some hypotheses which say that inflammation and oxidative stress can predispose to both heart failure and cancer. The sympathetic nervous system activation and renin-angiotensin aldosterone system activation, along with circulating natriuretic peptide levels and serpin A3 high levels, promote tumor growth in heart failure patients. Cancer by itself is a risk factor for the development of heart failure. And patients with cardiovascular disease have a higher risk of developing cancer. So they are interrelated on many levels. Not only that, when we treat cancer patients, these modern anti-cancer therapies can cause either transient or permanent left ventricular dysfunction. So there are many sad truths about heart failure in general. Both men and women have almost equal lifetime risk of heart failure. That means out of 5 individuals, 1 can have heart failure during their lifetime. But look at the 5-year death rate as well. The heart failure related 5-year death rate is as high as 48%. And as we all know, and you see in the chart, this death rate is actually much more than what we see with leukemia, intestinal malignancy, and lymphoma. So heart failure is by itself quite deadlier than many cancers. So how should we monitor these patients who are having cancer or cancer who are on drug treatment for cancer to look for cardiotoxicity? ECG is simple, non-invasive, and cheap, and it is a routine screening tool. Echocardiography would be yet another routine screening tool because it monitors various parameters including ejection fraction, fractional shortening, and global longitudinal strain. This also is considered a screening tool. For symptomatic patients and for future comparison, we should also check troponin and natriuretic peptide levels because these are very useful in combined use with imaging like echocardiogram in a symptomatic patient to see whether the exercise intolerance and shortness of breath are actually related to the cardiac involvement or not. However, the most preferred investigation of imaging, it would be cardiac magnetic resonance, and the MRI images will tell us about structural, functional, and tissue characteristics with myocardial perfusion disturbances. Even though the cost is high, it is very, very important that we use it if we really want to diagnose and confirm a patient with symptoms and probable cardiac involvement, especially in the early stages. ECG monitoring, either a routine ECG or sometimes a Holter ECG for 3 or 4 days may be needed. And we may at times see QT prolongation on a standard ECG, SCT segment changes, and sometimes conduction blocks. Tachyarrhythmias and intermittent conduction blocks may be seen on Holter monitor, especially in people who are suffering with intermittent symptoms. The cancer therapeutics related cardiac dysfunction, CTR-CD, it primarily refers to myocardial dysfunction and heart failure. Both the American and the European guidelines tell that if the left ventricular ejection fraction comes down by more than 10% of the baseline, or the global longitudinal strain is more than 15% of the baseline, then we'll have to conclude that this patient who is on anti-cancer drug is developed cardiac dysfunction, probably secondary to that. So there are two types, type 1 and type 2. Type 1 is quite toxic because there is direct death of cardiomyocyte by free radicals and oxidative stress, and the damage is permanent. Even with the initial administration of the drug, it happens, and there is persistent, permanent, and irreversible cardiac dysfunction. Sometimes the downhill progression may be stabilized. However, recovery back to normal is quite less possible. You can see doxorubicin, daunorubicin, and these anthracycline groups of drugs having this kind of CTR-CD. Another group, the type 2 group, which is less risky, would be the tyrosine kinase inhibitor type, where it is only a partial or temporary dysfunction of the cardiomyocyte, and it is usually reversible after temporary dysfunction. So how do we monitor these patients with the echocardiography? So if the initial echocardiography before we start the treatment, if it is less than 50%, we should try to avoid these drugs, chemo agents that can affect the heart. So they say consider cardioprotective drugs. So if the baseline is normal, that is more than 50%, and we start the treatment, after the chemo is over and before the next chemo is given, we need to do a repeat echo to make sure that there is no reduction in ejection fraction and there is no global longitudinal strain reduction by more than 15%. So if the ejection fraction or global longitudinal strain is abnormal, then we again avoid these drugs and you go back to cardioprotective chemo agents. And after treatment, once in 6 months, you do an echo and look for EF and GLS. And if there is any time there is reduction in EF or GLS, you again go back to cardioprotective drugs. And if there is no chemotherapy going, then maybe you can follow up once in 6 months to 12 months. This would be the cardiac MR monitoring images. Basically, we are looking for myocardial injury, either structural, functional, or tissue characteristics. During the cardiac cycle, when the cardia undergoes deformation and twist, there is changes in the structure and the strain in the MR images. So T1 mapping will help us to identify the diffuse fibrosis, and T2 mapping will help us to identify the myocardial edema, and the late gadolinium enhancement will diagnose the myocardial fibrosis or scarring, which is actually a permanent damage. How to manage heart failure patients with cancer? The treatment of heart failure has evolved over the last 40 years from just bed rest and fluid restriction. We moved to digoxin and diuretics, and then we moved to evidence-based medicine. This is the timeline of evolution of heart failure treatment, and so many trials have shown us that drugs like ACE inhibitors, ARBs, beta blockers, mineralocorticoid receptor antagonist, and in the recent years, angiotensin receptor neprilysin inhibitor combination and the latest SGLT2 inhibitors have played a very important role in heart failure therapy over and above the device therapy is also used, and sinus node inhibitors wherever needed. So based on the pathophysiological pathways, the renin-angiotensin-aldosterone system inhibitors like ACE, ARBs, and mineralocorticoid receptor antagonist, the neprilysin inhibitor with ARNI, and the guanyl cyclase pathway is blocked with vericiguat, and the SGLT2 pathway is inhibited by SGLT2 inhibitors and beta blockers inhibiting the sympathetic nervous system pathway. We have a multi-pronged beneficial effect on heart failure patients. Till recent years, till about 2020, the 5 pillars of heart failure treatment were ARBs or ACE, neprilysin inhibitor, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. Since 2021, we have the Fantastic Four for heart failure treatment. That means the focus is on ARNI, valsartan sacubitril combination, along with beta blockers, SGLT2 inhibitors, and mineralocorticoid receptor antagonist. And these main Fantastic Four is supported by other drugs like iron supplements, hydrolazine nitrate combination for renal failure, heart failure patients, and sometimes procedure like mitral edge-to-edge repair for those with severe mitral regurgitation, then other procedures and drugs. There are so many new trials that shows us benefit in terms of heart failure, especially in those with heart failure with reduced ejection fraction. The Paradigm HF trial showing benefit of sacubitril valsartan combination. The DAPA HF trial showing the benefit of the SGLT2 inhibitor dapagliflozin. The Victoria trial showing the benefit of vericiguat. The Emperor Reduce showing the benefit of empagliflozin are the trials that showed benefit. And since the last couple of years, we have changed from a conventional sequencing for compensated heart failure patients from step 1, 2, 3, 4, 5. The new sequencing is step 1, beta blockers plus SGLT2 inhibitors. And step 2 is ARNI, and step 3 is mineralocorticoid receptor antagonist if potassium is accepting. And all 3 steps are achieved within 4 weeks, and thereafter only up titration we do. All the mechanisms to be placed within 4 weeks of initiation of treatment. And then we also have management strategies for advanced heart failure, especially those with reduced ejection fraction. And this is as per the chart I've shown on table. And this is device therapy, including CRT, ICD, and some of the newer drugs like omecamtiv mecarbil. All these are have been identified along with ultrafiltration for those with cardiorenal failure. So in short, the take-home message would be cancer by itself is a risk factor for the development of heart failure. Patients with cardiovascular disease and heart failure have a higher risk of developing cancer. Heart failure is a progressive disease and needs aggressive management. Cancer therapeutic related cardiac dysfunction is a common problem and needs meticulous monitoring and treatment as it can cause transient and permanent myocardial damage. With recent advancement in the heart failure treatment, we can prevent and treat this cardiac dysfunction. Thank you very much.
Thank you so much, Professor Tom, for that enlightening lecture. I'd like to inform the attendees that we are really short of time, so probably we won't be able to take more than a single question. Is there any question here, please? Yeah.
Good morning, everyone. Thank you very much, Professor, for the wonderful presentation. Just a quick question. From the highlights, heart failure or cardiovascular disease are more prone to like develop cancer. And talking about cancer, we know it's a very broad term, you know, with different gene parameters involved, the p53, HER2, BR1, BR2, and likes. So from your data, which type of cancers are the most common based on your data?
So we do not have any specific data as to which particular cancer is the one that is most common. But in general, because we already discussed that there are common risk factors for both heart failure and cancer, including diabetes and smoking and genetic predisposition, these patients are prone to develop any malignancy, but most importantly, GI malignancy seems to be having the upper hand, gastrointestinal and colon.
Thank you.
My question is on duration of treatment, because you mentioned that some of them are reversible within 2 to 4 weeks. So do you keep them on the anti-failure regime lifelong? Do you keep it for 1 year? Speak on how long do you keep the patients on anti-failure regime?
So most of the times, these people will need long-term anti-failure therapy. But the most important thing is taking off the poison, that is the anti-cancer treatment that is responsible for this heart failure. Thank you very much.
Good morning, friends. So I have been asked to speak on transcatheter interventions in congenital heart disease and overview. So this is going to be the agenda of my talk. I'm going to take you through the timeline of interventions for congenital heart disease. Then we'll discuss about what has changed in last 3 decades in this very exciting field. Then I'm going to present to you some of the problems faced in LMICs and also share with you our philosophy and practice to face these challenges. And I'll conclude with some concluding remarks. So let's begin with the timeline of interventions for congenital heart. They started sometime in mid-60s with a procedure called as balloon atrial septostomy, which involves creating a hole in the interatrial septum so that we mix the saturated and the desaturated blood. This was essential for dealing with children who are born with transposition of great arteries, which means the aorta is arising from the right ventricle instead of arising from the left ventricle, and pulmonary artery arising from the left ventricle instead of from the right ventricle. Sometimes in mid-70s, we started closing patent ductus arteriosus and atrial septal defect using devices. Till that time, they were closed only surgically. But these procedures did not gain popularity because of very large accesses that were required, 23, 24 French, and the devices were not very versatile in terms of retrieving them and repositioning them. So they went into disrepute for some time. As you know, in late 70s, balloon angioplasty for coronary arteries became very popular, and balloon was the buzzword. So in congenital hearts, we started using balloons, much larger balloons, to deal with valves. So valvuloplasties became a reality in 1980s. In mid-90s, there were major refinements in ASD and PDA closures, and they became a standard of care because the devices became versatile and much low profiled. It was in early 2000 that we started closing ventricular septal defects with devices. And around the same time, we started implanting pulmonary valves in the right ventricular outflow tract. The last decade has seen resurgence of VSD closure, because what happened was when we started VSD closure in early 2000, the incidence of complete heart block really did not bring too much of popularity to this procedure. And so this procedure took a back seat for some time. But last decade, with better understanding of the conduction system and with newer devices, there was a resurgence of VSD closure. And then we also went on to close PDAs in preemies. We started expanding indications for pulmonary valves. And last but not the least, instead of doing BT shunts, now people are stenting PDAs. So what has changed in last 3 decades is our understanding of these congenital hearts in terms of our diagnostic capability. So the accuracy has really increased a great deal in terms of echoes, CTs, MRIs, and what have you. There has been a significant refinement in hardware, in guide wires, in catheters, in balloons, in long sheaths and devices. So also the experience and expertise of the operators has increased significantly. And many of the allied specialties like anesthesia, ICU care has really undergone a significant revolution. And as a result of this, the scope of interventions has increased significantly. The age at which we can intervene is getting smaller and smaller. We are able to deal with very sick kids who are hypoxemic, acidotic, and what have you. The safety and the efficacy of the procedures has improved significantly. And last but not the least, the predictability of the procedures, which is so very crucial in the developing countries. So now I'll just touch upon some of the problems in the LMICs. So as you know, the disease burden is huge and the resources are extremely limited. So this is what the Wall Street pundits would call as a double whammy. If you look at India, there are 300,000 babies approximately per year born with congenital heart, of which 1/3 of them will need some form of intervention, either transcatheter or surgical. And actually, we can cater to only 20,000 babies. So 80,000 babies per year get added to already existing pool of patients. So there are problems at every level because the primary health care is not evolved to that extent. So detection becomes a problem. Even after detecting these patients, for them to reach the proper referral center is also a problem because there are not many referral centers and the distribution is very skewed, mainly in the urban areas. So there is a problem with referral. And even when they come to the right place, I think we just don't have adequate number of surgeons, cardiologists, nursing staff, technicians to take care of them. So we are just able to treat around 1/5 of them. Now, poverty is a main problem, so apart from many other issues, and that we cannot deny. Almost 15% of the population in our country lives in multidimensional poverty, and 10% of them earn less than $2.15 per day. This is as per the UN data. And the GHI, we stand around 111th out of 125 countries, and this is the data from 2 European agencies. So all this gets translated into clinical impact, having, we get very sick patients, they come late in the course of the disease, they are malnourished, they are anemic, they're dehydrated. Many of them are septic, acidotic, and hypoxemic. So the outcomes really get impacted because of these kinds of clinical conditions. At the same time, there is a significant resource constraint. The healthcare expenditure is around 2.1% of our GDP, and more than 90% of the babies are without any form of health insurance. Fortunately, we have some government schemes, some state government, some central government schemes, and we are able to deal with these problems. There are just a few children's hospitals, maybe a handful, with meaningful pediatric cardiology program, and the advanced imaging technologies like hybrid suites and biplane cath labs are a rarity. And so are the other imaging technologies like intracardiac echo and fusion imaging. If I were to compare US with India, look at the population. We are almost 4 to 5 times the US population. They have one center per 1.6 million, whereas we have one center per 90 million. They have over 4,000 pediatric cardiologists. We barely have 500. They have over 300 cardiac surgeons. We have barely 40. And they have trained nurses, technicians, and therapists, whereas our nurses, technicians, therapists mostly learn on the job. However, we have learned early in our practice that save is not a 4-letter word. So we want to save at every point in time. The Western world till 2008 did not know what saving was all about. Till such time, Dow, FTSE, and CAC decreased by almost 50%. They needed half the banks to go under and the likes of Lehman Brothers to go bankrupt to understand what is saving. Fortunately, saving is a part of our culture and philosophy, and that has helped us a lot in taking care of these children. The second important thing that we have learned early in our practice, that failure is not an option because it costs, not only in terms of morbidity and sometimes even in terms of mortality, but I think most important in terms of economics. However, despite having all these problems, we have our own strengths as well, of eternal optimism, spirited, confident group of youngsters, ability to put in long hours of work without complaining, and are concerned for the economically challenged. Last but not the least, our ability to adapt. And I think all these things have made us take care of the population despite having limited resources. So our mantra has been, when the going gets tough, the tough get going. And our motto has been that we can do it. So I think the most important aspect has been innovations, and they are a must if we have to survive in this environment of limited resources. It is the need of the hour, and we have to innovate for ourselves. Developed countries are unlikely to fend for us. So innovations are right from innovations in our approach. So we need to play God, we need to play Robin Hood, and we need to play Daredevil. Playing God, we decide whom to treat. Some of the conditions like hypoplastic left heart syndromes or hypoplastic right heart syndromes, where the outcomes are not great, we may decide that we do nothing. Because with limited resources, if we were to use a lot of our resources treating these patients whose unnatural history is a big question mark, I think we'll be wasting our resources. So we have to play God sometimes. We decide how to treat because we may not be able to offer device therapy in every patient because devices are in some places more expensive than surgery. So we decide how to treat and we decide when to treat, like, for example, valvular PS, peripheral pulmonary stenosis. In Western countries, they may treat at a very low gradient, but in our country, probably we'll have to wait till such time the gradient is significant, till such time patients have hypertension, for example, in coarctation, or the lower limb pulses are really weak to be treated. We play Robin Hood by taking from the rich and giving it to the poor, tie up with social foundations and charitable trusts, negotiate and bargain very hard with the industry to get a cost which is affordable to many at the bottom of the pyramid. And then, of course, we were helped by our friends and colleagues in early part of our program, which has become difficult now to get things, especially consumables, from the friends in the Western countries. Both ways, it's difficult for them to give, and it is difficult for us to bring it in the country to be used for the needy and the unaffording. Playing Daredevil, although we don't recommend, but we have no choice in many programs, we have to re-sterilize the hardware, use less expensive consumables, and innovate procedures. So we re-sterilize many things, not in our current practice, but many years back, guide wires, balloons, long sheets, transeptal needles, and what have you. So using re-sterilized hardware, we have to have a stringent sterilization protocol. We have to have a good system of quality care. We have to test everything before using. And we must know when to and when not to reuse sterilized stuff. And it needs some expertise in deciding which are the patients and which are the cases where we can afford to use the re-sterilized hardware. So this is an example. It's an aortic stenosis, critical aortic stenosis with severe left ventricular dysfunction. This patient just cannot afford. It took him 30 days to reach my clinic, which is 15 kilometers from his place of residence. So we got him admitted in a charity ward, and we had at that time re-sterilized guide wires and balloons. So we did a balloon aortic valvuloplasty, and see, within 15 days, the left ventricle is squeezing normally. So the help that this child got, who came in a cardiogenic shock, went home with near normal left ventricular function. So using less expensive consumables, like using coils instead of using vascular plugs or devices. Many times we need to use clones instead of using the original products because they are less expensive. And we use some alternative devices so as to reduce the costs while closing perimembranous VSDs, while closing muscular VSDs, and while closing hypertensive patent ductus arteriosus. So this is an example of a patent ductus arteriosus which is closed using a coil. The coil costs just 3,000 to 4,000 rupees, whereas if you were to use devices, it would cost you nearly 40,000 to 50,000 rupees. Then you will ask me, why are the coils not used in every case? Because the control with which you can deliver coils is not as easy as you can deliver devices. So we have modified these techniques. So this is a delivery of the coil, which is delivered with the help of a catheter, which gives you a solid control. Our colleagues in South India, instead of using a modified catheter, they are using bioptome, as you will see in this case. They are using a bioptome. So you can control the delivery of the coil, and you can get almost similar result. The PDA is completely closed. So this is an advantage of using coils which can be delivered with a great degree of control. So you don't compromise safety, and yet you have equal amount of efficacy. Now, this is an example where we've used a PDA device, which is not the original product, but a clone, which is very similar to the original product, but we save at least 20,000 to 25,000 rupees in this. And similarly, in patients with ASD, so this is a case of a very large ASD, we have used a clone instead of using an original product. This is a case of a pulmonary AV fistula, and you can see again, we have used a clone instead of using the original product, thereby saving thousands of rupees for these patients. Now, as far as innovating procedures are concerned, we are using less expensive hardware, trying to modify the procedures, trying to reduce complications, and trying to see whether we can have a predictable outcome. So this is one of the techniques that we have adopted. Instead of using multiple catheters, we have used one catheter to measure pressures, make angiograms, and cross the stenotic valve. So this is a right coronary catheter, which has only one hole and therefore cannot be used for angiography. What we have done is modified it by making multiple holes proximally so that you can use the same catheter for angiogram, as has been done here. Then we have used the same catheter for measuring the pressure that you can see downstairs here. And then we have crossed the valve with the same catheter. After that, we have used a balloon. And then post-dilatation, you can see that the valve is beautifully opened. And we can see the pressure, which has dropped to nearly 1/3 its original pressure. Now, this is a case of pulmonary atresia, where there is no flow going from the right ventricle into the pulmonary artery. You can see that it is completely blocked. So in the Western world, they use what is called as the radio frequency wire. The cost of the machine is $100,000, and each wire would cost you more than $1,000. So instead of that, we are using a guide wire. Initially, we used to use a hard end of the guide wire, but that is a little more risky as compared to using a chronic total occlusion guide wires. So now we use what are called as CTO guide wires. And then you can start with a small balloon. Then you can use a major balloon, a larger balloon. And finally, you can see that there is a great antegrade flow. So there was initially no flow at all, as you see in the first angiogram. And in the last angiogram, you can see that there is an excellent antegrade flow. So the cost of this procedure is reduced significantly by using this CTO guide wires rather than using a rather than using the radio frequency wires. Now, there are many complications. I'm just going to discuss one, and that's the vascular injury. You know, many times after catheterization, you end up with a femoral artery injury. We realized very early in our practice that these were the four villains which were responsible for vascular problems: the intimal injury, inadequate heparinization, perivascular hematoma, and intravascular thrombus. So there were two key steps. One is accessing the artery, and second is compressing the artery. So what we did was that while accessing the artery, we see to it that you get the blood into the syringe, then you remove the needle, then you get the backflow into the syringe, and then you feed the artery. By doing this, you will never ever injure the intima while passing the guide wire, as we are doing in this particular case. So that really saves the intimal injury. And then while pressing, if you press too hard, there will be no flow. And so you will see here, you see the second there. If you press too hard, there is no flow. So while pressing the groin, we see to it, we keep a pulse oximeter probe on the great toe. And we see that we press just this far and no further, that there is a distal flow. It's not completely stopped. At the same time, there is no proximal hematoma. So you watch at the groin, watch at the pulse oximeter sine wave on the scope, and then decide how much pressure you can give. So this has helped us a great deal. Really speaking, we have hardly ever called a surgeon to look at the limb, and the chances of any vascular compromise have been close to zero. Now, this is another problem which we are able to solve. ASD device closure has become the procedure of choice. If you use a standard method of delivery, the success is in 70% of the cases. But when you try and use device closure for large defects with margin abnormalities, for large defects in children, the success rate may drop to 50%. And that is because of the problems of alignment and accommodation. So this is what I mean by a problem of alignment. So this is the ASD, which is seen there. And you can see that the device, instead of being parallel to the septum, is getting perpendicular to the septum. So this is a problem of alignment. We described a new technique in 2005, what is called as balloon-assisted technique. And I'm happy to say that this is the commonest technique used the world over for trying to close VSDs, which are complex. So this is what we do actually, use a balloon to support the device. So that is the left atrial disc. It is nothing but a dumbbell-shaped device. The balloon prevents the herniation of the left atrial disc across the defect, and it gives us enough time to release the right atrial disc. Once both the discs are delivered, then you can deflate the balloon, and you can see that how beautifully the device now sits across the interatrial septum and is released once we confirm its position on transesophageal echo and fluoroscopy. So this patient required a 40-millimeter device to close a 33-millimeter defect. The beauty of this technique is that it is simple, safe, effective, has a short learning curve. And as I said, most importantly, it is predictable in over 95% of the patients. Now, this is a case of a very small child, maybe 2 years old, has a large defect. You can see that, the flow across the defect there. And this patient, the left atrium is very small. So what happens is that when you try to open the device in the left atrium, there is just no space in the left atrium. So device falls across the defect into the right atrium, which is just not acceptable. So initially, people described a technique, what is called the left superior pulmonary venous technique. You engage the disc in the left superior pulmonary vein, and then you release the waist and the right atrial disc. What we did actually, we innovated this technique. Rather than calling it a left superior pulmonary venous technique, we believed that these are group of techniques wherein you can engage the left atrial disc, not only in left superior pulmonary vein, but in various structures. So we called it a left atrial disc engagement, disengagement technique. And we, for the first time, showed that you can engage the disc in the right superior pulmonary vein, roof of the left atrium, in the left atrial appendage, wherever. And if the disengagement of the left atrial disc was not possible spontaneously, you could disengage it using some maneuvers. And we described these group of techniques way back in 2013 and still have been used all over the world for taking care of children with large ASDs. And these are some of the other techniques. Instead of left superior pulmonary vein, this device, the left atrial disc, is being engaged in the right superior pulmonary vein. And when they don't disengage spontaneously, you see this, we are doing a maneuver of pushing on the cable, which is rather contrarian, to disengage the left atrial disc so that it falls in its position, closing the defect. Lastly, all these transcatheter interventions are going to have complications. They are an integral part of interventional procedures. You cannot escape them. They can be immediate, they can be late onset, some of them expected, some of them unexpected. And when you have limited resources, believe me, it's a Himalayan task. It's a lot of pressure on the system, not only in terms of money, but in terms of human resources as well. In sports, you must have heard this cliche, it isn't over till it is over. In transcatheter interventions, it isn't over even after it is over, because patient may get complication after many weeks or even after many months. In order to do this procedure successfully, you require a great deal of teamwork, a team which is comprising of members who are passionate, driven, committed, efficient, and effective. And as a leader of the team, you must know to share your dream. Your dream should not become everyone else's nightmare. That's the last thing. And that's why it is said that no one can whistle a symphony. It takes a whole orchestra to play it. And this is the prize. This is my very close friend, Dr. Ziad Hijazi, who worked in United States. This is how he looked in 1997. And this is how he looks in 2020. As handsome, you can see as charming, and look at his smile. And this is me, 1997, and in 2020. You know, my hair are gray. I have donned a pair of spectacles and my smile has disappeared. And now hardly any hair have been left to become gray either. So in conclusion, ladies and gentlemen, transcatheter interventions are here to stay. The scope is expected to expand. We are going to treat more smaller and morbid babies who will also get the benefit of these interventions. They are likely to become more safe and more effective. And as I said, they are getting more and more predictable. The supply-demand discrepancy will persist mainly in the developing countries. So saving resources is going to be mandatory. We believe less is more should be our philosophy, driven more by compulsion and not by choice. More innovations are required in this part of the world to serve the base of the pyramid. And this specialty, although challenging and demanding, is truly very exciting and very gratifying. So I think if I were to describe transcatheter interventions, I think this quote from Sir Winston Churchill says it all. Time is short, the odds are great, the margins small, and the stakes infinite. Thanks for your patient hearing, ladies and gentlemen.
Thank you very much, Dr. Delvey, for such a brilliant presentation. Now, due to interest in time, I would like to take one question from an online attendee, which is stating as follows. What will be the danger of giving all 4 pillar drugs for heart failure at the same time in comparison to the stepwise approach? And are there any studies to support the stepwise approach?
Really speaking, this is beyond the scope of my talk. And really, I don't know what actually 4 drugs that he's talking about. And really, I'm not into the treatment of heart failure. Somebody else may be able to take that question better than what I can take. Yeah, this is for heart failure. I mean, this talk is not on heart failure and certainly not on pharmacotherapy. And I mean, I'm not too good in pharmacotherapy, I must admit.
All right. Any other questions here? We'll take maximum one of them.
Thank you, Dr. Delvey. It's very interesting presentation from you. I'm Doni from Indonesia, and I'm from hospital which maybe one of the center of congenital heart disease, or in Java maybe. I would like to ask maybe several questions to you. First, maybe it was relatively common patients come with us with congenital heart disease with pulmonary hypertension, isn't it right? And how do you deal with that kind of patients? Do you treat it first for some duration of time, then you close it, or maybe just conservative treatment? It's first question. And then the second one, you say that it will be several complications after interventional procedures, some like thrombosis maybe. And then what it's interesting is device dislodgement after the interventional. And how common it happened in your hospital maybe first. And then second, how do you deal with this kind of things? You do it percutaneously or just open heart surgery?
Yeah.
Thank you, Doctor.
Great questions. Excellent. So the first question is on pulmonary hypertension. It's a very important question because many of the patients don't get treated early in infancy. And this part of the world, we see it not uncommonly. ASDs, VSDs, PDAs coming with severe pulmonary hypertension. Some of them are unfortunate to get Eisenmengerized and the shunt becomes right to left. And then they are beyond treatment by just closing the defect. Then they become candidate for medical therapy or a heart-lung transplant. But there are some patients who have high pulmonary artery pressure but low pulmonary vascular resistance. And there are ways of knowing this clinically by X-ray chest, by ECG, by echocardiography, exercise saturations, so on and so forth. So we call this multi-dimensional approach. And then take them to the cath lab and look at pulmonary vascular resistance, systemic vascular resistance, and then decide whether the patient is operable or not operable. If we feel that the patient is definitely operable, we'll just fix the hole. But if we have any doubt in our mind, we use an approach wherein we create a perforation within the device, what is called as a perforated device or a perforated patch if it was surgery. And if we think that this is not a great case and the chances of reversibility of pulmonary hypertension are very low, I think we treat it medically. When in doubt, never close is our philosophy. Never close completely, because the natural history of a Eisenmengerized shunt is much better than a closed shunt who has an irreversible pulmonary vascular disease. You will make him worse after closure. So either you close it partly or don't close it at all. The second question, also interesting. Of course, as I said, if you are going to do these interventions, there are going to be complications. And one of them is device embolization. If we end up with device embolization, we definitely try to remove the device percutaneously, but with a definite time limit. You cannot keep on trying for hours together and make a patient more sick before he goes into the operating room. The purpose is to have it as safe as possible. If we can do it within an hour, hour and a half, which we decide, and if we cannot do it, we let the patient go to the operating room and get the device removed and fix the defect. So that's our policy. Our incidence is close to 1%, I would say, of device embolization.
Thank you so much, Professor Dalvi. Due to paucity of time, I'd please request that any further questions for any of our speakers for that matter, including the online attendees, may be directed to the speakers themselves over email or through personal communication. Sir, if you allow me, could we share your email IDs with the attendees, those who have questions? Perfect.
My email ID is bharatdalvi@hotmail.com. You will realize from my age that I'm still a hotmailer.
Thank you so much.
As one word, no underscore, no dot.
We'll put their email addresses in the group as well for you to note. Thank you.
So, good morning to everyone. I'm public health specialist and I work mostly in epidemiology of infectious diseases and non-infectious diseases. And I took this challenge when Dr. Soham proposed me to talk about this topic. I understand during this morning we discussed some of the aspects that I'm going to talk about. So should a particular cancer screening program be considered for patients with diabetes or not? I'll take a perspective from the public health and health systems, not clinical as previous speakers. My apologies for very busy slides. I will pass quickly. I just wanted to show that the burden of diabetes is increasing. There is about 3% increase in diabetes mortality rates by age. lower middle income countries are having great increase. And you can see in this map, Africa will have an increase of about 134%, and you can see also other parts of the world with the increase in mortality. The burden of cancer is also well known. You see that according to the WHO, nearly 10 million deaths occurred in 2020, and the most common cancers occurring worldwide are breast cancer, lung cancer, colon cancer, and rectum and prostate cancers. Many cancers can be cured if detected early and treated effectively, as we saw in previous speakers' talk. So the global cancer burden is expected to rise significantly in the next 50 years, with about 40% increase seen in low and middle income countries, not only because of population expansion, but because also of increase in life expectancy, urbanization, changes in lifestyles, and rise in risk factors, including obesity. I brought this slide to show you some of the risk factors of cancer for males and females. And because I'm going to talk about diabetes in particular, I highlighted only certain aspects. This side is, I cannot see the full slide, but this side you can see here, males, and here, females. And the risk factors are part of those that are traditional, like tobacco, alcohol, and diet, etc. You can see high body mass index and high fasting plasma glucose among the main risk factors in both males and females. But there are many risk factors. Existing evidence indicates that risk factors among people with type 2 diabetes including cancers of liver, pancreas, endometrium, colorectal, as Professor earlier said. We observed association between type 2 diabetes and cancer could be either causal, means there is a link, or because of confounding from common risk factors such as adiposity. And this is important aspect, because many cancer patients come and we diagnose them with diabetes, and many diabetic patients can come at the clinical setting and we diagnose them with cancer. And sometimes we are not sure if it's a causal effect or it's just a confounding aspect. Some evidence points to the fact that there is some association between diabetes and cancer progression. And the prognosis of cancer with diabetes is better if the plasma glucose is well controlled. So I'm not going to explain this slide, but just to show you that there are multiple factors that are involved, as we saw earlier today. Multiple factors are involved in, genesis or the occurrence of diabetes mellitus, and some of the aspects were discussed today. Now, let me just talk about my topic. Early diagnosis versus cancer screening. And there is differences. Early diagnosis aims to identify at initial stages. If the cancer is diagnosed early, so we more likely can intervene, and the probability of survival will be better. and we will be less expensive in terms of treatment. Early diagnosis consists of awareness and seeking medical advice when we observe abnormalities, and access to clinical care and treatment services is also important. This is particularly important in low-middle income countries where access to care is challenging and limited. Cancer programs should be designed to reduce delays in and barriers to diagnosis, treatment, and supportive care. Screening, on the other hand, aims to identify individuals with findings that are suggestive of a specific cancer or pre-cancer condition, meaning before developing symptoms or signs. After screening, of course, we need to do further testing to come up with definitive diagnosis. Screening programs are effective for some, but not all cancer. You might know from your experience. And even when screening programs are established, early diagnosis programs are still necessary to identify those cancers that are occurring in people who do not meet the age or risk factor criteria for screening. Okay, I'm not going to go in detail, but there is a very good resource published by WHO where they actually compare, these two aspects: cancer screening and early cancer diagnosis. As the picture here shows, screening is done when the onset of symptoms is not present, before onset of symptoms, and screening is done at the population level, usually population surveys, etc. we do to detect certain conditions, in this case, cancer. Early diagnosis is done perhaps most commonly opportunistically, when the patient comes for any reason in clinical setting, and we, as clinicians, we suspect and we take advantage of the opportunity and test, and we may detect earlier stages. Okay. Of course, we need to take into account the benefits and the harms of cancer screening. Benefits are we can reduce severity and morbidity if we detect early. Most screening techniques are less invasive. We can reduce in this incidence, and we can also reduce mortality. Harms, perhaps we will overdiagnose, overtreat. We might find within the screening programs false positives and false negatives. And it's common because the screening tools that are available, they are not 100% specific or 100% sensitive. And we might pick some false positives and false negatives. There might be also some physical and psychological harms during the screening tests. So I brought this slide just to say that within public health, and particularly for NCDs, we need to think about continuum of care, which starts actually with education, raising awareness, and starts with health promotion. Patients who are better educated, who have better literacy levels, will go for screening more, perhaps most probably, than people who have lower education level or lower literacy, particularly regarding certain common conditions. Early diagnosis, treatment, and then after treatment, also compliance is important. Once someone was asking me why chronic conditions, non-communicable chronic conditions are very expensive. They become expensive if we allow it to develop to more advanced stages, particularly stages that require more complex treatment and care. So, as we say in Portuguese, preventive is better than cure. So we have to anticipate, and this is perhaps common, perhaps well known for all of you. We usually tend to intervene within preventive strategies before onset of disease, primary prevention. When the disease is already established, we try to do secondary prevention by early detection and try to avoid or try to halt the progression of the disease. And if the diagnosis is done at advanced stage, we still try to do what we call tertiary prevention, which is to reduce complications and try to confer better quality of life or quality of life that is possible in that conditions. Okay, so my answer to the topic, diabetes and cancer, should a particular cancer screening program be considered for patients with diabetes? Of course, the answer is yes. Although I don't have, and I didn't see any effectiveness studies about this, but from the literature that I reviewed, I would say that both diabetes and cancer burden is increasing globally. So we should screen cancer patients for diabetes and vice versa. We also should screen diabetic patients for cancer. The same way, the screening of complications is requested regularly for diabetic patients, for example, for high blood pressure, retinopathies, or kidney function neuropathies, and other conditions. We also should request for screening of common occurring cancer among male and female patients. I did not mention here which cancers because this will depend on the context. And when I was reviewing the literature, I saw the prevalence of different cancers varies according to the different countries and different contexts. This is important, but another aspect also that cancer is underreported condition because of the nature of the condition, the disease, but also the scarcity of registry systems in place. So not every country have a good system to register cancer cases that actually are diagnosed within their health system. That's a big problem. But I would say, based on age and locally screening programs that are available, for example, for HIV program, we have in place screening for cervical cancer for women, or for breast cancer also, but I know most countries are implementing intensively low-cost cervical cancer screening. The same way we can also, based on our own context, our own epidemiology or profile of cancers, we can do screening, targeted screening, like if for men, if it's lung cancer, we should include in diabetic patients lung cancer screening. And particularly if there are other risk factors associated, then we also need to look at that. Early detection of cancer in diabetic patients will contribute greatly for better prognosis. If we delay diagnosis of cancer among diabetic patients, then the prognosis will be compromised and the life expectancy will be reduced. Maybe there are other reasons, but based on the quick revision and also to complement the previous presentations, this is what I have to say, and many thanks for your attention.
Thank you, Professor. Basically, this is not a question per se, but a statement one, to compliment you for the presentation, and two, looking back at the recent theme for the World Diabetes Day, education to protect tomorrow. Okay, so it's like we are not only focusing on diabetes per se, but all the NCDs. And the education, I may say, does not only reflect to us educating our patients, no. It imbibes us educating our patients, educating ourselves, and then the masses. That's the only way we can protect tomorrow. And what is that tomorrow? That tomorrow is the long-term complications of all these combinations. Looking at diabetes, cancer, obesity, the metabolic syndrome, all others, cigarette smoke and the likes, they are all systemic factors influencing wound healing. I am bringing that because basically I'm a practicing general surgeon, okay? The burden we face in such situation emanating from these systemic causes of delayed or impaired wound healing is the main cause for the theme for the just concluded World Diabetes Day, education to protect tomorrow. So we must pay attention to that aspect and ensure we educate the masses, educate our patients, and then ourselves. Moving forward, finally, with regards to screening for cancers and the likes, if you know the patient is not going to benefit from that screening, you don't do it. Okay? For like, say, a particular stage of pancreatic cancer, even if you diagnose, the patient is going to, suffer and then die. Having a benign prostate cancer, not having any harm to the patient, just allow. You don't screen. But for cases like cervical cancer, hence the great interest now in mass screening, because there is tendency for you to save that life. And then, of course, now we have the vaccination and the likes. So that is all I have for now. Thank you very much for a wonderful presentation, and thank you, everyone.
Thank you very much for the comment. And I fully agree, screening just for the sake of screening, no, and if you can actually make a difference by screening, and if we have in place programs that allow us to diagnose, our context will define that. If we have screening programs already in place, we need to think also to include our diabetic patients or other patients with chronic disease, as we saw also cardiovascular patients who also may develop cancer. But many thanks for your presentation. Education is very important for all, physicians or health professionals, populations, masses, and patients as well. Thank you.
Thank you, Dr. Masakoi. Thank you, Professor Siddharth.
Okay.
If you won't mind, can I take one more question from one attendee very quickly?
Thank you so much, Doc. So maybe if I understood your presentation very well, and if I want to take a practical message from this, is that it's important for us to screen for cancers among diabetic people with diabetes. But for now, there's no recommended screening program for that population. And what we should do is we should try to apply rigorously the adopted screening algorithm for the various cancers in that region. Basically, it's a from a public health perspective, we should be trying to improve. Should we be trying to improve adherence to basically implementation science now, making sure that we really we encourage clinicians to adhere to the recommended screening programs? Is that
there are guidelines of screening in different contexts, but in low middle income countries, my perspective is that you should look at your context, what is available, what type of cancers can be screened, and as the colleague said, what benefits it brings to the patient. Of course, diabetic patients tend to develop cancer earlier than other groups in terms of age group. So if there are programs that can benefit patients, like cervical cancer screening for women is in place, you can think about including while caring for diabetic patients to screen for female patients to screen for. Same way for example, prostate cancer or others. If these screening programs are not in place, you will disturb your health system and create some confusion. But you need to think about diabetic patients that they are more prone to develop cancers. So, of course, you can also do within the care, you can also do different things, including palliative care, or if you can intervene, you can. So I don't want to leave a specific recommendation. It will be depending on case by case. I didn't find anything specific to low middle income countries in terms of guidelines, not even from WHO. The only thing is that it highlights is that diabetic patients are prone to develop cancer, and we need to think about that when we are caring for diabetic patients. That's the main take home message. Thank you.
Thank you so much, Professor Siddharth. For any further questions, I hope you won't mind if we share your contact, your email address with any of our attendees interested. Thank you.
Thank you so much. At the outset, I must thank Merck Foundation for this wonderful event, and Krishna Medical Science and Research Center, which is from where I am, for giving this opportunity. And also I welcome you all to India for this educational feast. Now my topic is association between cardiometabolic syndrome and cancer. During our first lecture, already association between diabetes and cancer we have discussed. Now I am taking forward this diabetes, association of diabetes and cancer forward, and pertaining to the cardiometabolic syndrome and cancer. So what do you mean by cardiometabolic syndrome? That it is the constellation of metabolic dysfunction which is characterized by different things like, thank you so much, because I was not visible. I'm only audible. Now I am visible. Thank you so much.
Perfect. Now, doctor, please continue.
Thank you. So when we define the cardiometabolic syndrome, it is a constellation of metabolic dysfunction which is characterized by insulin resistance and impaired glucose tolerance, atherogenic dyslipidemia, hypertension, and intra-abdominal obesity. So these are the different components. And when we go forward, these components like central obesity is excess abdominal fat, and which is more seen in Asian Indians. Then high blood sugar, that is hypertension, elevated blood sugar, which is because of insulin resistance or impaired glucose metabolism, and abnormal lipid profile may be high triglyceride, high LDL, low HDL, and cholesterol. So these are the different components of cardiometabolic syndrome. And this is the thing that in central, there is cardiometabolic syndrome, which is because of more abdominal visceral fat leading to insulin resistance. And these are the things like cardiovascular heart disease, hypertension. These are the components: hypercholesterolemia, hypertriglyceridemia, high LDL, liver disease, and definitely intra-utero programming. This is the more area for the research, because nowadays one researcher, great researcher, Dr. Yajnik, he's from Pune, he's researching on this intrauterine programming, that when the female diagnosed as a GDM, that is gestational diabetes, and if she's carrying a female in utero, when the patient delivers the female, already the ovum number is defined. So there are 3 successive generations which are under diabetes milieu. So these are the causative factors. And now what are the effects? That is the cancer, neurological defects, autoimmunity and diseases, gastrointestinal disorders, mood disorders, and developmental disorders. So it will lead to many things, and it is having multifaceted causative factors. Now we have already gone through the statistics, but just I will give you a glimpse of this. So what is the prevalence of cardiometabolic syndrome? According to the latest estimates globally, nearly 25% of all adults have cardiometabolic syndrome, and prevalence of metabolic syndrome among adults in India would be somewhere between 20 to 25%, that is 1/4 of population. And prevalence is consistently and significantly higher among women than men. So because there is increasing number of GDM. Asian Indians have unique atherogenic dyslipidemic profile and a South Asian phenotype, that is they have more visceral fat, and when we compare the body mass analysis, the Asian Indians have more fat when we compare with same BMI and same weight with the Caucasians. So they are more preponderance for the cardiometabolic syndrome. And now, so when there are 2 risk factors together, there is a terminology which is emerging like when the diabetes and obesity are together, which is called as a diabesity, or lipid tension when dyslipidemia and hypertension. So there are many permutation combination emerging to the cardiometabolic syndrome. Now, when we see for the prevalence of cancer, the estimated number of incident cases of cancer in India in 2022 was around 14,61,421. That is, crude ratio is 100.4 per 1 lakh. In India, 1 in 9 people are likely to develop cancer in his or her lifetime. And when we go for the diabetes, it is 1 in 4 person. Now it's very fastly increasing. And lung and breast cancers were the leading sites of cancer in males and females respectively. The incidence of cancer cases is estimated to increase by 12.8% in 2025 when we compare with 2020. So cancer remains a leading cause of death globally, with an estimated 9.6 million cancer-related deaths in 2020 according to the WHO. And why it is important? Because there is substantial burden on a country's economy and also on the public health. So when we consider this cardiometabolic syndrome and association with the cancer, we have to address all these things because it is a multifaceted disorder. Now, what is the connection? That is epidemiological evidence that numerous epidemiological studies have highlighted the significant association between these two. Cancers such as breast, colorectal, pancreatic, and liver have shown particularly strong connection. Recent research has provided compelling evidence that cardiometabolic diseases significantly contribute to the risk of developing various types of cancer. So this is the data. Though the slide is not very clear, it is a cumulative index of cancer and cardiovascular disease when body mass index and waist circumference we have compared, and it is steadily increasing parallelly. So what may be the potential mechanism? Though it is the area of research, still we can conclude some potential mechanisms like chronic inflammation. So cardiometabolic syndrome often leads to chronic inflammation, which is known a main driver for cancer development. Insulin resistance is elevated insulin levels, which can promote cell growth and contribute to tumor development. Dysregulation of adipokines. These adipose tissues secrete adipokines, and when there are more accumulation of this adipose tissue or more fat accumulation around your abdomen or visceral fat, we definitely increase in the adipokines, which can influence cancer cell behavior. Then some key findings are there, like shared risk factors in between cardiometabolic syndrome and cancer, such as obesity, sedentary lifestyle, and poor dietary choices. These factors contribute to the development and progression of both conditions. So I think from first speaker, we are repeatedly revising all these things, like lifestyle modification is the cornerstone for all these non-communicable diseases. Inflammation as a common denominator. The chronic inflammation is a hallmark for cardiometabolic diseases and is increasingly recognized as a driving force in cancer development. So we can judge by the inflammatory mediators such as interleukin-6 or tumor necrosis factor alpha have been implicated as promoting tumor growth and metastasis. And we can see in diabetes also, or in the pre-diabetes also, these inflammatory markers, they are definitely higher in number. Insulin resistance and hyperinsulinemia. As insulin resistance is a characteristic of type 2 diabetes, which leads to elevated insulin levels in blood. So insulin not only regulates glucose, but it also acts as a growth factor. So when elevated insulin levels have been linked to cancer cell proliferation and survival. So there is hyperinsulinemia in initial stage, though whether it is pre-diabetic or diagnosed diabetic, it will definitely lead or it will motivate for going towards the cancer. Then alteration in hormones. Hormonal disturbances such as elevated level of insulin, insulin-like growth factor, and sex hormone can influence cancer risk. For instance, elevated estrogen levels are associated with breast and endometrial cancers, which are more common in women with obesity and diabetes or pre-diabetes. Now, microbiota and gut health. Now, this is pulling attention of the researcher because apart from pancreas, microbiota or gut is considering the second treatable organ when we consider diabetes. So, emerging research is highlighting the role of the gut microbiota in both cardiometabolic diseases and cancer. So dysbiosis or an imbalance in gut bacteria has been linked to the inflammation and cancer development, but mainly to the colorectal. Therapeutic implications, what would be the implications? Like understanding the link between these diseases opens up a new avenues for the therapeutic intervention. So targeting shared pathways such as inflammation or insulin signaling may provide novel strategies for cancer prevention and treatment in individual with cardiometabolic diseases. And now, as my esteemed speaker previously already discussed about the screening and early detection, identifying high-risk individuals with cardiometabolic diseases and implementing cancer screening strategies tailored to their risk profiles may lead to earlier cancer detection and improved outcome. As I already discussed that this screening would be as per your need of the population. This is not the universal screening, and already he has discussed that is awareness, screening, treatment, diagnosis, treatment, and adherence. And this is not the linear case. This is the circular case. Like after adherence, again you have to screen for every year, whether it is emerging again or whether it is progressive. So though it may be a diabetes or obesity or cancer, this is a circular way. This is not the linear pathway when we consider as awareness, screening, diagnosis, treatment, and adherence to the treatment. Now, when we see about the specific cancer types, first is the breast cancer. So studies suggest that postmenopausal women with cardiometabolic syndrome have an increased risk of developing breast cancer. There are certain data also. If you want, you can contact me. Hormonal and inflammatory factors may play a role, but still this is under research. Colorectal cancer, CMS, that is cardiometabolic syndrome, is associated with an elevated risk of colorectal cancer, insulin resistance, chronic inflammation, and also involvement of gut microbiota are implicated in this relationship. Liver cancer, now that is first is pancreas, second is gut microbiota, and the third emerging organ is the liver, because when we consider or when we screen diabetic patient, definitely we screen for the liver. So non-alcoholic fatty liver disease, that is NFLD, a common component of cardiometabolic syndrome, is linked to liver cancer because NFLD progress to the NASH, to the cirrhosis, and after that, more commonly, more than 50% will emerge into hepatocellular carcinoma. So in diabetic patient, we have to think of screening liver also by doing initially ultrasound. Now we will go ahead for the prevention. So lifestyle modifications, which is the crux or which is the cornerstone, such as diet and exercise, are the key to preventing both cardiometabolic syndrome, cancer, or such non-communicable diseases. Routine screening can help to detect cancer at an early or more treatable stage, but this is as per your community or whatever the prevalence rate or according to the age or according to the symptoms and signs. So treatment part, understanding the links between cardiometabolic syndrome and cancer can inform treatment strategies. Targeting common pathways like inflammation could be the promising approach. The importance of multidisciplinary approach involving oncologists, diabetologists, and other specialists whenever we require the different specialty aspect or treatment. And the most important is patient education. The role of patient education in managing, in preventing, and in screening this condition is of immense importance. So what are the innovative cardiometabolic syndrome approaches? First is personalized or tailor-made medicine, which this intervention based on the genetic profile. Nowadays, the genetic profile or genetic mapping or genetic testing is on the way of our research. And the fourth organ which is emerging is mitochondria, because when there is, it may be said that mitochondrial dysfunction, it may precede or it is the causative factor or it may follow the diabetes. So mitochondrial genetic mutations and the oxidative stress, which is the biomarker of mitochondrial dysfunction, these are the few things which are now under research. Lifestyle intervention, pharmacological breakthroughs. So there are different OHA, like oral hypoglycemic. One we have already discussed is metformin. This is having robust data, which is having some anti-cancer effect. Also, it causes reduction in the central obesity, it causes reduction in the hyperglycemia, and also it causes reduction in the insulin resistance. So we can give metformin when we are treating with the PCOS or NFLD. This is the drug of choice. The emerging biomarkers offer early insight, like I have already discussed about oxidative stress, which indicates the mitochondrial dysfunction. So lifestyle modifications like encompassing dietary changes and tailored exercise. Targets of mitochondrial syndrome and are the adaptation of healthy lifestyle, weight loss, and the control of comorbidities like hyperglycemia, dyslipidemia, arterial hypertension, and different things. The long-term goals are the prevention of type 2 diabetes, cardiovascular events, and the other metabolic syndrome-related outcome. This is the treatment goal. And so, in conclusion, the association between cardiometabolic syndrome and cancer is a multifaceted and crucial area of research. The evidence supporting this link underscores the need for the holistic approach to healthcare that addresses both conditions simultaneously. The intricate relationship is driven by the shared risk factors like inflammatory pathways or processes, hormonal disturbances, and metabolic dysregulation, maybe insulin or maybe gut microbiota or liver dysfunction. By recognizing the intricate interplay between the cardiometabolic syndrome and cancer, we can develop better prevention and treatment strategies and improve the overall health outcome of individuals affected by this condition. So, collaboration between the healthcare professions, researchers, and public health authorities is essential to address this burden effectively, because this is now the public health burden and also the economical burden to the country. So, let's put our hands together and combat with these epidemics. Thank you so much.
Thank you very much, Dr. Tamankar. It's a very perfect presentation. I'm Dr. Alec. I'm internal medicine physician from Indonesia. I think that patient profile from Indonesia in Indonesia about the diabetes is not too different. So some center in Indonesia start to think that we should prevent the diabetes backward from the pre-diabetes. So we had some research about pre-diabetes that they already had insulin resistance and chronic inflammation and other else. So do you think that should we start the screen about the cancer from patient with pre-diabetes or patient with risk of the diabetes, not waiting the patient until they got the diabetes? Thank you very much.
Thank you. It's a very good question. Now, when we think of pre-diabetes, the HbA1c should be in between 5.8 to 6.4. So when patient comes to you with pre-diabetic, already there is failing of beta cell function. Already. So it's the complications are sets in when the patient comes to you with pre-diabetes level. So never let the patient go. You just ask the patient, give intense lifestyle modification with the diet and exercise, and just screen the patient every 3 monthly for the HbA1c. If previously it was 5.9 and after 3 months it becomes 6.2, that is, it is progressive. So start with metformin so that there will be reduction in the insulin resistance. Maybe the cancer risk is there, it will definitely address. And if the patient is having strong family history, if the patient is having some signs and symptoms, then you can go for the screening. But initially, as a primary prevention, secondary prevention, we never think of screening for the cancer unless and until the patient is having strong family history or the patient is having fatty liver like type 2, type 3. Or if the patient is having progressive very fastly, then only go for the cancer screening. Otherwise, routine screening like HbA1c, blood sugar, kidney function, liver function, thyroid, and lipid profile. These are the yearly screening program in our institute. Every yearly we can do that. But the cancer screening, we will go for the history, signs, symptom, and the progression.
Thank you very much.
Thank you.
So anyone have any questions? One more question we can go for. Yeah. One more question.
I think I have given very good speech on.
Thank you. Thank you so much, doctor.
Thank you.
Yeah. Thank you.
Thank you. I'll use this. I think this is much better for me. Yeah. First of all, welcome and good afternoon. I thank Merck Foundation and KVB for giving this opportunity to me. Today, I'm going to talk about primary and secondary prevention in cardiovascular toxicity due to systemic anti-cancer therapy. Now, this topic is very vast. It starts from cardiology and goes into the oncology. Being cardiologists, I have a limited knowledge of anti-cancer therapy, but still, I've discussed with the three of my oncologists while preparing the presentation. I'll try to complete this within half an hour, but I know it is not easy because it is a vast topic. So all of us know that the cancer incidence is increased not only in developed countries, even in developing countries. Fortunately, there are newer anti-cancer therapies which has reduced the mortality in these patients. However, the meta-analysis has showed that almost 50% of population who are cancer survivors are developing cardiac toxicity, and significant number of population is dying because of cancer therapy related cardiotoxicity. So you will understand why this topic is important. One side, we are treating the patients, they are getting cured, but because of this anti-cancer therapy, they are developing cardiac toxicity. So to find out, or for the primary prevention and secondary prevention, the most important thing is risk stratification. You should know which patient will get severe cardiac toxicity and what are the chances of developing cardiac toxicity. Once we stratify these patients, we can target these patients and try to give less toxic drugs. We can give protective drugs, cardioprotective drugs, and we can reduce the cardiotoxicity. Now you can see there are two person. One is a young patient without any comorbidity, and if he's receiving anti-cancer therapy, the chances of developing cardiotoxicity is definitely less. On other side, elderly patient with hypertension, diabetes, dyslipidemia, she already has received chemotherapy, radiotherapy. You can understand she already has received cancer therapy, which is more cardiotoxic, and now she again requires anti-cancer therapy. She's at high risk of developing cancer-related cardiac toxicity, anti-cancer therapy-related cardiac toxicity. So the dimension of cardiovascular toxicity extends from the what are the chances of developing cardiac toxicity for that particular patient. It may be low, it may be intermediate, or it may be high risk. So our job is to find out what is the possibility of developing cardiac toxicity for that particular patient, and what is the probable severity. That is also important. So it may be a mild symptoms, or it may be a severe symptoms like fulminant myocarditis or severe heart failure. So that also we should know which anti-cancer therapy causes what kind of cardiac toxicity. So if suppose patient is receiving a anti-cancer therapy where the toxicity is mild and the patient profile is low risk, then probably we need not to do a further evaluation. You can proceed with the anti-cancer therapy. But suppose patient is high probable of developing severe toxicity, obviously you have to involve the cardiologist in the treatment protocol, do the thorough analysis, evaluation of a cardiac status, and if any cardioprotective drug is required, or if you can change the medicine which is less cardiac toxic, you can continue with that therapy. High chances of mild toxicity, you can continue therapy, but however, if low risk, even if a low risk of developing severe symptoms, you have to go cautiously. So our aim is to deliver most permissible anti-cancer therapy from the cardiovascular perspective and most effective therapy from the oncology perspective. So if you see the dynamics of cardiovascular toxicity, even you screen this patient, they are going to develop cancer therapy related toxicity during the treatment, maybe middle of the treatment, or maybe end of the treatment. So such patients require cardiac surveillance throughout the therapy, and you have to find out these patients, and probably you may need to interrupt the anti-cancer therapy. And few of the patients require long-term cancer survivorship surveillance. So if you see the spectrum of cancer therapy related cardiotoxicity, it can be because of cancer itself, because it may directly involve the pericardium, heart disease, or It may be due to shared cardiac risk factors, means the risk factors common to the heart disease as well as cancer, both can be together and can lead to the cardiac disease along with the cancer in a individual patient. And obviously other component is a cancer therapy related toxicity, which we are going to discuss today in detail. So we have different cancer therapies. Cytotoxic therapy, everybody knows, anthracycline, chemotherapy, 5-FU, they are directly causing myocardial injury. They are actually cytotoxic drugs. So then their other group is targeted therapies, where they go and target the cancer cells. However, few of the targeted therapies also causes damage to the heart. These are tyrosine kinase inhibitors. They will have off-target, on-target effects. Simultaneously, it can cause cardiac toxicity also. Immunotherapies are well known to cause myocarditis. The incidence is rare, but if it causes myocarditis, fulminant myocarditis, the mortality is high. So it is very important to detect the cardiac toxicity of these drugs early and treat. Otherwise, we may lose the patient due to the therapy. So cancer therapy can cause cardiomyopathy. Cardiomyopathy is the commonest toxicity, and anthracycline is the commonest drug which can cause type 1 cardiotoxicity. Type 1 means it causes irreversible damage of the myocardium. So it is very important when you are starting anthracycline, you should screen these patients properly with the echocardiography. I'll come to that later. And as I said, these drugs causes irreversible damage. There is another group, HER2 monoclonal antibodies. These generally causes reversible cardiotoxicity, and this is called as type 2 toxicity. And as I said, immunocheckpoint inhibitors, these drugs causes myocarditis, and fulminant myocarditis can lead to the death. So when you are using a individual drug, you should know what kind of toxicity patient may get. That is more important. Another toxicity, I think it is okay, you can see it. The arterial hypertension. Few of the drugs, especially vascular endothelial growth factor monoclonal antibodies, can cause accelerated hypertension. If it goes to the malignant hypertension, you have to stop the medication and you have to treat the hypertension as early as possible. Otherwise, it can kill the patient. Coronary artery disease in the form of vasospasm, vascular thrombosis. The commonest drug is 5-FU. We all know that this is a commonest drug which can cause vascular toxicity. Then arrhythmias. This is important side effect, or I can say cardiac toxicity. You have to diagnose it as early as possible. If they develop ventricular arrhythmias, we may lose the patient during the therapy. Few of the drugs causes QT prolongation, especially vascular endothelial growth factors, arsenic trioxides. Whenever you are starting these drugs, you should monitor the ECG to see the QT prolongation. If the QT prolongs beyond the level, it can cause vascular cardiac arrhythmia and death. Valvular heart disease is not that common with this. Pericardial effusion is very common with these drugs, especially anthracyclines, arsenic trioxides, alkylating agents. Pericardial construction is not common. Hypertension is also not common. So as I said, the risk can be reversible, irreversible. It can be acute, chronic, especially anthracyclines. You give anthracyclines today and the patient develops cardiotoxicity after 1 year, and it can be late onset. So this is important. This slide is from European Society of Cardiology Guidelines 2022. We never had a proper classification of cardiotoxicity. Different studies use different classification. That's why the incidence is varying in different studies. But now European Society of Cardiology has defined the symptomatic heart failure and asymptomatic heart disease or LV dysfunction in patients undergoing cancer therapy. So if it is requiring inotropic, any heart failure requiring inotropic support, mechanical support, then it is classified as a very severe heart failure. If it requires hospitalization, it is severe heart failure. If it is requiring intensification of diuretic therapy, it is a moderate. If patient is okay with mild symptoms, then it is defined as a mild symptomatic heart failure. Severe is defined on the basis of echocardiography. If the ejection fraction is less than 40, suppose a patient, you have started chemotherapy, his ejection fraction is normal, and after chemotherapy his ejection fraction becomes less than 40. It is categorized as a severe LV dysfunction. In this situation, you need to stop the anti-cancer therapy. You cannot continue that drug, or otherwise patient will develop permanent heart failure. So imagine one side you are curing the cancer, and other side you are giving a heart disease. Moderate if the ejection fraction reduction happens to the level of 40 to 50 and the GLS is reduced by more than 15%. I'll come to that later, what is GLS and other things. Mild symptomatic symptomatic disease when ejection fraction is more than 50, but there is a drop in GLS by more than 15%. Okay, so as I told you, pericardial diseases, you can see this kind of situation can happen with a anti-cancer therapy. Patient is on anti-cancer therapy and patient develops a pericardial effusion, a freely moving heart in the pericardial cavity, and there is a compression from the pericardial fluid. Such patients requires emergency pericardiocentesis, otherwise they will have a cardiac arrest. Another interesting case we had, opposite side, you can see other side. So that patient had actually bronchogenic carcinoma, underwent bronchoscopy, and then he developed tension pneumothorax. Patient came in a cardiogenic shock. X-ray was showing like air around the heart into the pericardium, and BP was 70 systolic. We have to aspirate urgently. But later on we realized it was bronchopericardial fistula. Only aspiration didn't work. We had to put the catheter across the pericardium to the bronchus, and we closed it. So probably I can continue without slides. Is it okay? Okay. Standing idle, other when I'll talk. So subsequent slides, I know what is important is what we have to go with the risk stratification. For the risk stratification, the most important thing is to take a proper history and physical examination. So if the patient is having diabetes, hypertension, dyslipidemia, all these patients are going to develop they are at high risk of developing cardiac disease. Okay, so if you are discussing about the arrhythmias, the commonest arrhythmia is atrial fibrillation. The most important about atrial fibrillation compared to the general population is that Chadwick score doesn't work with the cancer patients because it underestimates the risk of thromboembolic phenomena. Probably we have to be aggressive to treat with anticoagulation in these patients. And another side, cardiac toxicity, which is high risk, they can develop QT prolongation, torsities, repointis, and cardiac arrest. You should detect this as early as possible before continuing with the same drug. You have to stop the drug, correct the QT, and probably you can start with other drug. So Heart Failure Association and International Cardiovascular Oncology Society has given the risk stratification chart. So while risk stratifying these patients, there should be personalized approach, systemic approach without delaying oncology treatment. This is very important. You should not waste time in investigation. When you feel that this is a low risk patient, not going to get a low cardiac toxicity, you should start the therapy as early as possible. You should not delay the therapy. Cardiac tests like ECG, biomarkers, cardiac imaging should be offered as per the patient's need. And then you have to categorize into the low risk, intermediate risk, high risk. Low risk patient should go for a therapy immediately. High risk patient should go for a cardiac evaluation and further testing. So as I said, history and clinical examination is very important. Presence of or absence of pre-existing cardiovascular disease is important, especially a patient is having past history of heart failure, coronary artery disease, any current cardiac symptoms. Probably patient may not be known for any cardiac disease, but actually patient may be having active cardiac disease along with the cancer. Like patient may be having heart failure symptoms, although it is not diagnosed as a heart failure previously. So cardiac symptoms should be asked for. Family history of premature cardiovascular disease. If the patient has family history, strong family history, high chances of developing heart disease in that particular patient. And any previous cardiotopic therapy he has received with a drug dosage, especially anthracyclines. If patient has received anthracycline in the past, the dose, cumulative dose is already crossed, then high chances of developing cardiac toxicity with that drug again. So ECG is recommended in all patients starting for the cancer therapy. If underlying ECG shows some clues, cardiac disease, patient should be referred for the cardiac evaluation. You can see in the ECG, upper ECG is normal and lower ECG you can see the low voltage that indicates probably pericardial effusion or LV dysfunction or kind of a cardiac infiltration. So ECG basic is important. It can give information about chamber dilatation, conduction abnormalities, arrhythmias, baseline arrhythmias, prior myocardial infarction. In patient with abnormal ECG, as I said, all patients should go for the cardiac evaluation. QT is very important. You have to learn how to calculate the QT. If normal QT is up to 450 millisecond in males and 460 in females. If the QT is baseline QT is more than 500, you have to avoid the QT prolonging drugs, anti-cancer therapy. If the baseline QT is normal and if you are using QT prolonging anti-cancer therapy, you should monitor ECG for the QT prolongation. And you can see the QT prolongs, then you can get that kind of VT. Another thing is, generally as a cardiologist, I use Bazet formula for the QT calculation, but the Cancer Association or the International Cardiology Oncology Society suggests Fredericia correction formula for the QT, because we know that QT changes with the heart rate. So you have to standardize the QT. Biomarkers, troponin I and troponin T along with the anti-proBNP. There is a limited data, but studies have shown that it can predict subclinical heart failure, and you should be do a cardiac surveillance in these patients. So whenever it comes to the cardiovascular imaging, the echo is very important investigation. If suppose echo is not possible, or if echo is not giving good images, then you can go for cardiac MRI. But the problem of cardiac MRI, there is a limitation of the availability. So whenever I'm talking about echo, it is very important to understand echo can be fallacious. There are different methods of calculation of ejection fraction. We use M mode, we use B mode, we use biplane Simpson method, but the recommended method by IOS is Simpson method. When we use M mode, only one dimension is taken and the machine assumes the volume of the LV and it gives the value. So it can be fallacious. In the Simpsons, we take a 4-chamber and 2-chamber. We take a 2-plane area and rest of the things still machine presumes and gives the ejection fraction. But for that, you should have a good image quality. If image quality is not good, then you cannot trace the myocardium. You can see in this, you can see here, you cannot see the image. You can see the border, endocardial border here clearly. You can trace it properly. Here you are not able to see. So such patients requires myocardial contrast echo. Okay. Sometimes that is also not possible. In that situation, you have to go with a cardiac MRI. Systemic arterial BP measurement is very important whenever you are recording echo, because you are not recording only one echo. That patient may require follow-up echo throughout the therapy. And as I said, ejection fraction is load dependent, after load or preload dependent. If the intravascular volume changes, ejection fraction may change. If BP changes, ejection fraction may change. And for another interesting thing is inter or intra-observer variability is almost 10%. 5 to 10%. Suppose I do echo in the morning, I may give a ejection fraction of 55%. Same person, I myself on a same patient in the evening may give a 60%. So 5% is a inter-observer and intra-observer variability. So ejection fraction is very rough method of assessing the LV contractility. And we know that when ejection fraction drops, we are too late. Already there is a damage to the heart. So that's why global longitudinal strain rate is measured. This is a new method where you can, this is independent of the load. In the inter-observer variability is less. It gives the deformation index of the heart. Normal GLS is minus 20, if it drops more than 15%, it is a specific to show that there is a subclinical LV dysfunction. And obviously 3D is preferred method because 3D can give accurate ejection fraction and cardiac volumes. It doesn't presume anything. It tracks all the points of the LV and it can give a reproducible ejection fraction. All the fallacies of ejection fraction we know, but at least inter-observer and intra-observer variability will be less. Okay. And obviously, if echo is not showing good image, then cardiac MRI is the best method. The image quality is good. Only problem is availability, cost. If you want to repeat it, then again cost goes high. Other specific test, radiation, nuclear imaging, but it is with radiation. It is least preferred. Functional assessment. If suppose you are suspecting coronary artery disease and you are starting anti-cancer therapy, which can cause coronary artery disease, you can go for a stress echocardiography, perfusion MRI, and other lot of things. Genetic testing. Just I'm touching upon this. It is not recommended at all, but there are some early investigations which shows that probably anthracycline associated LV dysfunction or immune checkpoint inhibitor associated myocarditis can be detected with the genetic testing. So probably in future they will do genetic testing and they will decide which drug to be given. So as I said, primary prevention aims to avoid minimizing the development of cardiovascular damage, and secondary prevention in a patient who already developed the cardiovascular disease or already have LV dysfunction, you have to prevent the further progression of the dysfunction or other cardiovascular toxicity. For secondary prevention, we have to minimize the use of cardiotoxic drugs. We can use a cardioprotective drugs like ACE inhibitors, ARBs, beta blockers. Anthracyclines, we can use a dexazoxane or liposomal anthracyclines and the statins. So this I'll skip because I already discussed. So as I said, HFA ICOS, as per the baseline age and baseline risk factors, it has given the risk stratification. H for high, M for moderate, and just don't go into details. I'll just briefly tell. Any patients above 75 years, most of the anti-cancer therapy are included into high risk. Any patient with a hypertension, if we are going to use vascular endothelial growth factor, because it causes hypertension as a side effect. So a patient is having hypertension, uncontrolled pressure, and you are starting that therapy, it is included in the high risk. So we have to control the therapy. You have to closely monitor blood pressure in that particular patient. Previous exposure to anthracycline is high risk for most of the anti-cancer therapy. So if the patient has received anthracycline previously, you should be very cautious. And if the patient has received HER2 inhibitors like trastuzumab, that is also risk factor for the trastuzumab. Any patient with a heart failure, high risk for all the patients, all the anti-cancer therapy. And any other like post bypass surgery, severe valvular heart failure, heart disease, stable angina, arteriovascular disease is also risk factor for most of the anti-cancer therapy. As I said, QT prolongation, vascular endothelial growth factor, BCR-LB inhibitors, arsenic trioxide, you have to monitor QT in these patients. Ejection fraction less than 50%. Just remember, you have to send this patient first to the cardiologist. Let him start the cardioprotective drugs, and you start the anti-cancer therapy. And throughout the therapy, you have to again monitor his ECG, biomarkers. Only important thing is that you should use same imaging modality. Suppose you have started with a 3D, later on you are using transthoracic echo, again you are using with cardiac MRI, it will not work. If you are using 3D, before cancer therapy, you continue with the 3D. So I'll just go with the specific anti-cancer therapy as it is little lengthy. I'll try to focus mainly on the commonest anti-cancer therapy. Anthracycline therapy mainly used in a CA breast, gynecological cancer, sarcoma, lymphoma. It causes reactive oxygen species generation, it causes DNA damage, and it kills the cancer cells. Similarly, same reactive oxygen species can be found in a myocardium and damages the myocardium. That is the mechanism of action of cancer treatment, as well as that is the mechanism of action in a cardiac toxicity. So it can cause acute cardiotoxicity in the form of myocarditis, heart failure. This can happen within week of a treatment. The commonest is chronic cardiac toxicity. That will happen within 1 year. If it happens within 1 year, it is early. And if it happens after 1 year, it is late. Most of the commonest cardiotoxicity is within 1 year. And if you see, it is a cumulative dose dependent. The toxicity of anthracycline is dose dependent. That's why we have to calculate its cumulative dose. If the dose goes more than 550 milligram per meter square, the risk increases significantly. So for these patients, primary prevention is manage the cardiovascular risk factors, hypertension, diabetes, blood pressure, dyslipidemia. Dexamethasone should be considered in a patient who are high risk. As I told you, LV dysfunction patients, cumulative dose is high. You should use this ion chelator. This will prevent binding of this drug to the myocardium. Liposomal anthracycline should be used in a high-risk patient. Liposomal anthracycline is a bigger molecule. It goes to the cancer cell, but it doesn't go to the myocardium. And as I told you, ACE inhibitors, beta blockers, statins should be used as a cardioprotective drugs in high-risk patients. Dexamethasone is an ion chelator. As I told you, it binds the topoisomerase 2 beta and prevents anthracycline binding. Also, it prevents that anthracycline drugs to go to the myocardium and damage the myocardium. It should be given in 10:1 dose 30 minutes prior to the each anthracycline therapy. And this is a just chart for the surveillance protocol. ECG is must for all patients. If any abnormality in ECG, sent to the cardiologist. Transthoracic echo, basic transthoracic echo is indicated in this patient. And 12-month post-treatment, if it is mild risk or high, low or moderate risk, it should be done in all patient after 12 months of the completion of therapy. If the patient is in high risk, you have to be very cautious. You have to monitor these patients with a transthoracic echo and NT-proBNP. So if the patient develops very severe or moderate toxicity, in that situation, you have to interrupt the drug and you start a heart failure therapy. HER2 target therapies. HER2 means it is used for the invasive breast carcinoma or early and metastatic gastric carcinoma. HER2 proteins are inhibited, and that just causes inhibition of the cancer cell proliferation. Same HER2 receptors are present on the myocardium. Once we inhibit that, when we give this drug to kill the cancer cells, it will inhibit the myocardial HER2 receptor also. And that will prevent the growth and repair of cardiac muscles. So it's like a physiological phenomena. That's why the good thing is that if you stop this drug, the toxicity will, patient will improve his ejection fraction. Suppose you start the medicine, he develops his LV dysfunction, you diagnose it early, stop the medicine, his LV will become normal. Incidence is high, 15 to 20%. That's why in all patients, either low risk or high risk, echocardiography monitoring is very important, because this is a reversible toxicity, not in all patients, but most of the patient if you diagnose early. And as I told you, 3rd month post-treatment, 12-month post-treatment, we should go for echocardiography, because sometimes they will develop late toxicity. Moderate to severe toxicity, you have to stop the medicine. As I told you, moderate to severe means patient developing heart failure symptomatically. Severe asymptomatic LV dysfunction more than less than 40% ejection fraction. You assess this patient after 3 weeks of interruption. If the patient's LV function improves, we can re-challenge this drug again in this patient. But suppose if there is a persistent decrease in ejection fraction for more than 8 weeks, or 3 times you had to interrupt this drug, then it should be discontinued. It is contraindicated. 5 of you Mainly 5-pu and its product capecitabine used for the colorectal, breast and gastric cancer. It causes DNA damage, RNA damage. The commonest toxicity is myocardial ischemia due to vasoconstriction, coronary artery thrombosis, cardiomyocyte death because of infarction. And the nitrates and calcium channel blockers should be used as a cardioprotective drugs. This will cause vasodilatation and it will prevent the vasoconstriction during the therapy. Vascular endothelial factors, mainly monoclonal antibodies, which are given IV, or vascular endothelial growth factor, tyrosine kinase inhibitors, which are given orally. You can see once the vascular endothelial growth factor is inhibited, this will not cause vascularization and tumor growth will die because of ischemia. These drugs mainly causes hypertension as a commonest side effect. Hypertension is a class effect, occurs within hours or days of the therapy. It is a dose dependent and usually subsides, reverse after discontinuation of vascular endothelial growth factor inhibitors. Heart failure is not that common. QT prolongation is very important side effect because it is preventable. If it is not looked into, patient can develop ventricular arrhythmias and patient instantaneously can die because of cardiac arrhythmias. So BP monitoring during each visit is important if you are using this drug, and QTC monitoring by ECG is also important in these patients. And what is the threshold for the treatment of the blood pressure in these patients? If the blood pressure is more than 130/80, you have to treat, especially in high risk patients. 140/90 if it is low group patient. If patient develops hypertension more than 180/110, you have to stop the medication. And obviously hypertensive emergency requires BP reduction very fast, otherwise they will develop end organ damage. And as I told you, QT monitoring. If the QT goes above 500 or a patient develops TDP, we have to stop the medicine, correct the QT. Now there are many causes for QT prolongation. Hypokalemia, hypomagnesemia, calcium problem, which is common in this patient because they are vomiting and they are developing electrolyte imbalance. Also drugs like tricyclic antidepressant or macrolide antibiotics, they also contribute for the QT prolongation. So you have to find out the cause and correct that. This probably I'll skip. BCR-ALB, which is used in a CLL, all of us knows. First generation has a lesser side effect. Second, third generation has almost all kind of cardiac side effects. Butyron tyrosine kinase inhibitor is now latest drug which is used for lymphoid malignancy and CLL. So the commonest side effect of ibrutinib is atrial fibrillation. You can predict the atrial fibrillation if the baseline ECG shows LA dilatation. If there is a LA overload pattern on a ECG before starting this therapy, you should avoid this drug. Otherwise, there are high chances that this patient will develop atrial fibrillation. And as I told you, if they develop atrial fibrillation, high chances of developing the clot and cardioembolic phenomena. Multiple myeloma drugs, mainly it causes the proteasome inhibitors and immunomodulators causes all kind of the toxicity. Most important toxicity is heart failure and the venous thromboembolism. So for that, you should actively, whenever patient is of multiple myeloma, you should actively see the venous thromboembolism and treat or give a prophylactic anticoagulation in high risk patients. Heart failure is one part is because of this patient develops cardiac amyloidosis also. Multiple myeloma itself causes cardiac amyloidosis, and obviously you are treating the drug with a cardiac toxicity. This I'll skip. Okay. So RAC inhibitors, MEK inhibitors, mainly used for melanoma in a specific mutation. They cause hypertension. In this patient, blood pressure monitoring is important. And also ECG is recommended because they are known to cause a QT prolongation. Cyclin dependent kinase inhibitors, generally they block the G1/S1 phase, and this also potential for the QT prolongation. Whenever it is a QT prolongation, you have to monitor the ECG. ALK inhibitors, EGFR, endothelial growth factor inhibitors. What I am trying to tell that you should know which drug you are going to use for that particular patient and what are the probable side effects in that particular patient. Accordingly, you have to investigate and serially follow with that particular investigation. So it causes mainly metabolic problem. ALK inhibitors causes metabolic problem. EGFR inhibitors causes the heart failure as a side effect. This I will skip. It is not commonly used. This is very important drug, immune checkpoint inhibitors. Recently, again interest in metastatic melanoma and non-cell small cell lung carcinoma and RCC. The mechanism of action is it actually normally the immune checkpoints inhibit the activation of the T cells. So these checkpoints are present on the cancer cells. So whenever T cell goes to the cancer cell says that I am from you only. And the T cell thinks that, oh, this is part of the body. So these checkpoints, when you inhibit, then that drug goes and damages the cancer cells. Similarly, these checkpoints are present on the heart also. And once they activate the heart cells also, it will cause activated against the heart cells also, it will cause myocarditis, and sometimes they develop fulminant myocarditis. Although side effect or this toxicity is not common, but if happens, almost mortality is more than 40 to 50%. So in this patient, when you're suspecting this, you should start methylprednisolone as early as possible. If methylprednisolone is not working, you go with the second line immunosuppressions. But diagnosing this toxicity is important. These are the rare drugs. I'll not go into the details. Androgen deprivation therapy. Now we have different therapies like a GnRH agonist, antagonist, first generation anti-androgens. All the hormone therapy causes metabolic problem. The least common, the least toxic drug is GnRH antagonist. So HERO trial has showed that this is a less toxic than any other hormone therapy in this androgen deprivation therapy. It is used mainly for prostate cancer. And the mechanism is it causes hypogonadism and metabolic problem. So metabolic problem, then you have to monitor all CAD risk factors and other things, diabetes, lipids. Okay, endocrine endocrine therapies also causes, majority is vascular venous thromboembolic risk with a tamoxifen, and toremixfen can cause prolonged QT interval. So we need to assess this metabolic factors for the aromatase inhibitors. Arsenic trioxide is known to cause, it is commonly used in leukemias and myelomas. It can cause QT interval prolongation. Weekly ECG monitoring is very important in this patient. As I said, they can develop Tosidis, depointis, and ventricular arrhythmias and cardiac arrest. Taxans has less toxicity, which is commonly used in a breast cancer, lung cancer, ovarian cancer, but most of the patient develops asymptomatic sinus bradycardia. Other patients may develop cardiomyocytic cardiac dysfunction, especially when it is combined with the anthracycline. So this is the least cardiac toxic drug, but then still you have to monitor if you are combining with the anthracycline. So that is also important. If you are using 2 or 3 combination of drugs, the synergetic effect may be different rather than individual drug. And alkylating agents, cisplatin can cause vascular disease, especially which is used in testicular cancer, and cyclophosphamide can cause hemorrhagic myocarditis, heart failure. So after completing cardiac anti-cancer therapy also, this patient requires surveillance. Who requires surveillance? High and very high risk baseline CV toxicity. Once you risk stratify this patient, and a few of the patient will turn into the high risk patient, these patients should be screened despite after completing the therapy. Specific anti-cancer therapy, patient receiving doxorubicin more than 250 milligram per meter. Now RT I have not covered because my topic was systemic anti-cancer therapy, but any patient who is getting RT with radiotherapy with doxorubicin, you need a long-term follow-up. Then moderate to severe cardiac toxicity during cancer therapy. Patient is low risk, but you have started anti-cancer therapy and during the therapy, they have developed the cardiac toxicity. This patient also requires long-term surveillance. And new cardiovascular symptoms or new asymptomatic abnormalities on echocardiography during the therapy. And what you need to do? A low risk group, probably you go with the annual CV risk assessment. Moderate risk group, you go with a transthoracic echo every 5 years if the cancer survivor is from the childhood or older son. If the patient has diagnosed with a cancer in the childhood, he has been treated with anti-cancer therapy, his cancer is treated, he is adult, but still he requires every 5-year transthoracic echo. Even if the patient is in moderate risk. High risk group, you should do every 2 yearly. And if the patient is adult, then you can go every 5 yearly. So concluding my talk, cardiac risk assessment is crucial prior to the any anti-cancer therapy that will categorize the patient into high risk, very high risk group, or moderate group, mild group. That will help us for the long-term surveillance also. Risk stratification should be based on the basis of history, physical examination, cardiac investigation like ECG, echo, if required cardiac MRI, or other investigations. Cardiology referral is essential when the patient is into the high risk or very high risk group, because preventive treatment is required before starting any anti-cancer therapy, especially cardiac toxic drugs. Patient developing cardiac symptoms during anti-cancer therapy should be referred to the cardiologist for the management and heart failure treatment. Team approach is very important. Collaboration between cardiologists and oncologists is very important. Oncologists may be best in treating with anti-cancer therapy, but probably he may not able to manage the cardiac disease. So cardiologists should be involved whenever there is a high risk patient. And long-term surveillance in cancer survivors is also important point which we should not miss. Once we treat the cancer, once the patient is cured of the cancer, we need to know that this patient should be followed to prevent or to cardiac toxicity may develop even after the therapy, and you should treat accordingly. These are the references. Mainly, most of the slides are from my the ESC guidelines. They have elaborated very in detail. If you want to go, you can see that guidelines. Thank you.
Thank you so much, Professor Shelke. As we can probably all of us see, your presentation has been very popular, especially with the online attendees. And should you allow, we can even share a copy of the presentation with them for their information.
Sure, no problem.
Thank you. Yeah. We just have time to accommodate one question, probably, if anybody has it.
Bonjour tout le monde.
Yeah, good morning.
Okay. Merci pour la présentation. Et je voulais poser une question sur les patients qui sont hypertendus diabétiques et qui présentent les dyslipidémies, qui sont sous anticancéreux. Si leur hémoglobine glyquée est entre 7,5 à 8%, est-ce qu'il faut les mettre sous metformine ou sur insulinothérapie? C'est ça, non?
Yeah, can somebody translate the question? Yeah.
She's asking patients that are diabetic with dyslipidemia and then have cancer. Should they be treated with metformin or being on insulinotherapy?
Okay, so it's regarding heart failure she is asking. So metformin is a safe drug in heart failure, but now there is a new therapy like a dapagliflozin which has shown cardioprotective effects. So if you want to treat heart failure and diabetes, dapagliflozin is a best drug because it has diuresis action also, it has long-term cardiac remodeling action also, and it has anti-diabetic activity also. That way metformin is a safer drug in a diabetic patient and heart failure.
Good afternoon, ladies and gentlemen. It's great to be part of this Africa-Asia meeting, and it's very nice to connect with all of you who are present on site, and of course our very esteemed delegates who are present off site as well. I think the topic for the day, which has been allocated to me, is related to challenges in management of patients with Cushing's syndrome and the rational use of glucocorticoids in clinical practice. And let me just tell you right at the onset that I think in my career as an endocrinologist, I think this is the most complex and a most challenging domain to work with, and the challenges continue to percolate on every aspect of patient management. Being a hardcore clinician, what I have tried to do in this complex subject is that I have tried to put together various clinical scenarios to bring home the clear messages so that, I think it's easier to relate to these messages rather than just put together a didactic talk with etiology, pathology, and so on. So let's move forward with that. So when we talk about such a classical case of Cushing's syndrome, the first ever case where Harvey Cushing described it and talked about it, things tend to be slightly kinder to us. But when we talk about Cushing's syndrome and its clinical presentation, what I'd like you to relate to is a fact that these symptom complex always depend upon the underlying pathology. So when we talk about the underlying pathology, I think I'll just pick out the pointer, please. So if we are talking about something which is, I'd rather use from the computer, so I don't have to turn. So if you're talking about ACTH dependency, or if you're talking about an ACTH independent state, that's how we kind of broadly look at Cushing per se. Each of these pathologies are related to extraordinarily different symptom complex. So there is no prototype that we are talking about. And we mean by that is that earlier on, when we want to make the diagnosis to kind of put together effective management, you want to diagnose your patients early on in the disease, isn't it? But that point in time, your symptom complex is going to be decided entirely by the pathology. Not only that, the age group makes a big difference over here. So if I talk about an infant, the pathology changes completely. It is usually associated with adrenal carcinomas, and that is going to give you totally different set of symptom complex. And the symptom complex again changes out there to a very elderly gentleman who presents to you with a possibility of Cushing. And I think you can relate to this man's face. He hardly has any symptom or sign of Cushing. That is the degree of variability that we are talking about in managing this group of patients. Why wouldn't it move? And also we need to understand there's a big spectrum that we talk about. So on one hand, we are talking about this extraordinarily florid presentation of Cushing. At the other hand, we are talking about this gentleman who is very incidentally picked up to have Cushing syndrome. So again, the spectrum is very different. So don't expect this kind of classic faces all the time. What happens is sometimes the whole progression of disease is so very subtle. Like this particular gentleman, he's a medical doctor, and he never thought there was anything wrong with his face. All that he felt was he's gaining weight and he needs to look after his diet and exercise better than what he's doing. And all his concern, this weight is not very good for you. That slow the progression of disease can be. And if you can just kind of look at the timelines that I'm talking about, his actual disease process had begun somewhere here. Okay, maybe just between 10 to 15 years. And by the time he came to attention, he was 27 plus. So it can take a number of years before which the patient can be recognized. It's also not necessary that we always get this kind of a striae and this kind of a plethora on the face of the patient. Its present is very easy to pick up. Its absence never ever helps you. Presence of myopathy or other catabolic signs are again not very common in certain age groups, particularly children and adolescents. Also in children, the symptom complex is extraordinarily different. They can just present to you with growth delay or short stature, like this particular twins, where the girl is doing very well in height and the boy looks stunted, and that could be one of the presentation. It could be presentation of a pseudo precocious puberty, this actual early onset of puberty, but it's nothing to do with gonadal axis like a normal puberty. It can even present to you just like a PCOS like presentation and symptom complex, and that could add to your problems fair amount really. It could be totally asymptomatic or subclinical. Patient may not have any symptom complex, but the biochemistry is going to take you towards Cushing as a diagnosis. Not only that, the etiology of Cushing emerges from your clinical presentation, from the various cues which are lined up and which we ought to pick up. Can you see this nail? It has got a white front, a middle which has got a black band, and again then a white band. That is a sign of how ACTH has progressed in this particular patient, and that degree of pigmentation tells me A, of course it is ACTH dependent, and B, its likelihood of ectopic Cushing syndrome. In patients with adrenal masses, they can present with virilization in a lady. The voice changes, the hair loss changes, the hirsutism comes up, and in a boy, it can present with gynecomastia. That was the only presentation in the child, and one of the surgeons just decided to put him through plastic surgery, told him to go home, only to get recurrence of gynecomastia. That's when he came to us and we realized he had an adrenal adenoma as a problem really sitting out there. This girl, who obviously looks so very Cushingoid, has one of the most important cue which you can never afford to miss. Can you see this blue dot on her lip? That is a cue to tell me it's a genetic disease, and multiple family members in her family who never went to doctors, when we call them for screening, had Cushing syndrome. It can be that subtle as a presentation. So if I have now put across to you that the symptom complex can be A, variable, B, very, very subtle. The reason of telling you this is that this subtle presentation, like just weight gain or blood sugars which are deranged or hypertension, it can happen in any metabolic syndrome. And that's a commonest denominator with which Cushing presents. Such presentations as hypokalemia, ecchymosis, muscle weakness, and osteoporosis are very specific to Cushing, but they are much less common as signs and symptoms of presentation. And that adds to major difficulty in making diagnosis in this group of individuals. And it goes without saying, ladies and gentlemen, that if I have such a huge clinical spectrum of severity of disease, even biochemically, my diagnosis is going to be stretched within the number of tests which are available. I'll have to use the test in keeping with the clinical picture, and not one single test applies as a blanket statement across your patients. So if I tell you this is a most florid case of Cushing syndrome, and you'll agree with me, this is a very early onset Cushing syndrome. This is a lady with a milder Cushing syndrome. This is a patient who's typical metabolic syndrome, PCOS, but I'm worried whether she has Cushing syndrome or not. And this is a man who presents with typical symptoms and signs, but believe me, he's a case of what we call as a pseudo Cushing syndrome. One test cannot fit all of them, and you'll have to use your test very wisely, because you cannot afford A, to miss the diagnosis, B, to produce a false positive, because the price that you pay for either of them is just too huge. So you have set of tests which are available under as a quantitative test and as a qualitative test. But please understand that these tests have different degree and grade of sensitivity with which the results work. So early on in disease, it's a late night salivary cortisol which will be positive. Little later, it's an overnight dexamethasone suppression test which becomes positive, and urinary free cortisol becomes positive much later, which means that it is less sensitive a test parameter to work with, right? So if I on the other hand, if I want to talk about something specific, because I cannot create false positive tests with a huge number of noise sitting out there and try to discriminate who is the true noise versus just the false positive parameter. Overnight dexamethasone test is specific, but there are group of patients which will show up as false positive. And how do I deal with them? Deal with them by using low dose 2-day standard dexamethasone suppression test, and that gives you a good amount of specificity. So if I now apply tests to these group of individuals, in this lady, it doesn't matter which test you use. It just doesn't matter. Everything is going to work beautifully well for you. But if I'm talking about this mild Cushing, I ought to be using late night salivary cortisol, eliciting the rhythm of cortisol which gets disturbed as the first sign of Cushing syndrome. Whereas if I'm talking about this gentleman, where I want something very specific, because I cannot afford a false positive test, the price that you pay for a false positive test is just too huge. So in that kind of a case scenario, I will use 2 days of standard dexamethasone suppression test. And this is borne out by multiple large series of data which are available, which talk about the sensitivity and specificity of dexamethasone suppression test as a screening parameter, as a very, very effective tool that you can handle. Once this part of the story is kind of proven that patient has endogenous hypercortisolism, we want to work with ACTH to find out whether it's ACTH dependent disease or otherwise, and only then proceed further. ACTH independent disease, which comes from adrenal gland, sometimes can have this false positive data, and you need to be again conscious about this aspect, including which platform you're using for ACTH test as a parameter. So be careful, because it's a very powerful tool if you've used the right platform. MRI is the second set of tests that you will carry out in an ACTH dependent disease, but MRI ought to be done with specifics. Your radiologist should be very careful and taking care of these different dimensions of MRI, which need to be addressed to increase the yield of this MRI. Because if you don't locate it in MRI, you will have to move over to inferior petrosal sinus sampling, which is a very, very invasive test, and it is a difficult test which can be done only in few centers. Okay, and also please understand that this IPSS, as we call it, has to be under CRH stimulation. You cannot do it under basal conditions, because you can't have an invasive test which is not giving you your correct answer, because my next step is now going to be surgical intervention in the patient. So treatment and its challenges are as follows. It is most common cause of Cushing syndrome is pituitary ACTH secreting tumor, and it has to be addressed by a very experienced neurosurgeons, because 90% of your tumors are 5 to 6 millimeters in size. So the persistent or surgical failure can occur in anything up to 30%. Recurrence of the disease can occur in other 40%, which essentially means that there is a big number which will require second line of management. And this second line of management comes from repeat surgery to radiotherapy as a possible as possible options that we are talking about. So can I predict who's going to recur? The answer is big no. It's very difficult to predict that. Yes, if you have a very well localized tumor, the probability of cure is very good in the hands of neurosurgeons. But believe me, these are the tumors where you don't become so lucky every time. The recurrence, by its sheer nature of pathology, occurs at the same site of the primary tumor, and that of course helps you to deal with it further. And again, then we need to address either a second surgery, which the results are so poor that we have given up on that. Unless it has happened by a neurosurgeon who's not very experienced, then we'd rather have our neurosurgeon go in second time because of the sheer volume of experience that they hold. Otherwise, the patient will have to go for radiotherapy. Radiotherapy, by its sheer nature, has sort of, yes, it is effective, but it is a slow process that we are talking about. So the response tends to be good. It's about 80%. It's a slow process. It's an ongoing process that we are talking about. It is safe in terms of secondary adverse events which emerge from radiotherapy, but new pituitary deficiencies keep emerging on an ongoing basis, which need to be monitored and effectively treated as well. So in about just one slide of summary that if I can just dole out, it is a challenge. It's a challenge across different domains of management, but it is also necessary because patients go through such huge morbidities if their diagnosis is delayed or they are left untreated, as you can see over here, right from opportunistic infections, deep vein thrombosis, central venous sinus thrombosis, avascular necrosis of the hip, and major fractures in the spine, even in younger children, is what we have seen, which is very, very sad to see, really. It requires a multidisciplinary approach towards its effective management, and everybody has to sort of be having a common dialogue so that patient management becomes more effective, really speaking. If I now move on to my next domain of topic, this is another challenging topic that we talk about, which is glucocorticoid-induced adrenal insufficiency and hence the rational use of glucocorticoids in clinical practice. And this is what I'd like to highlight. This is a very common entity that one comes across, but it has to be dealt with and addressed with the primary care physician or an internist who has used and started the glucocorticoids as immune modulators. So what is it that we want to know about this topic? What we want to know as clinicians, who gets glucocorticoid-induced insufficiency state? Which are the tests one can use to confirm that there is adrenal insufficiency? How should glucocorticoids be tapered or withdrawn so as to lessen the disease burden which emerges from adrenal insufficiency? How do we confirm that the axis has recovered to safely stop glucocorticoids ongoing usage? So first thing first, how prevalent is this condition? Where depending upon the duration and the dose of glucocorticoid that is used, it can be very huge burden, and patients who are on oral glucocorticoids on an ongoing basis, 50 to 60% of them can develop it. Rest of the use of glucocorticoid, be it inhaled or topical, has less burden of insufficiency which emerges. One of the data has suggested that the intra-articular steroid injection based on small subset of patients suggested that it is fairly large amount if it is consistently being used like more than 3 to 4 injections per year on an ongoing basis, can produce fair amount of insufficiencies. What are the risk factors which produce this state of glucocorticoid insufficiency? Well, it depends on mode of administration. It also depends upon which glucocorticoid is used in terms of its half-life and its potency, and if there are coexisting drugs like which sort of either enhance the metabolism of glucocorticoids or reduce the metabolism of glucocorticoids, which are going to change the half-life of this particular glucocorticoids. So when I talk about systemic administration and hence the emerging risks of glucocorticoid-induced adrenal insufficiency, it follows under following heading. Unless there are multiple doses which are used per day, and especially there is a bedtime administration for more than 2 to 4 weeks, patients don't develop glucocorticoid-induced adrenal insufficiency state. Amongst the inhaled glucocorticoids, high doses given for more than 6 months, like a compound like fluticasone, which is used for more than 6 months in high doses, such compounds will give adrenal insufficiency, otherwise it is not very common. Intra-articular injections depend upon how repeated the injections and the doses which are used, and whether these joints are inflamed to produce enhanced absorption of glucocorticoids. Again, same story applies for the percutaneous applications. Inflamed skin, extensive applications, large volume of applications, occlusive dressings, all of it are going to enhance the absorption and hence the risk of insufficiency. All routes of glucocorticoid use, whatever is the route, ultimately work through systemic circulation by their absorption, and that brings about suppression of both CRH and ACTH, the result being the cortisol secretion is suppressed and the adrenal androgen secretion which is suppressed, but aldosterone secretion is not suppressed, which essentially means our management will include only glucocorticoid based replacements. Can we reduce the risk of this particular entity? And well, try and use the lowest effective dose, but ultimately we need to realize this is not our decision. It is a decision of an internist who's actually begun the glucocorticoid as a regime, that being as an immune modulator. So the dose, the duration, the frequency of administration, the potency of steroid, everything is going to be decided by them. Once a day dose is far more favored than dose which is broken down into multiple doses. Bedtime dose will always inhibit the ACTH surge which occurs early in the morning, enhancing the risk of insufficiency. And one needs to understand that it should be used as a deceleration process in a tapered down manner. How quickly you taper it down and how fast you can bring it down to the minimalistic dose will depend upon the duration of preceding therapeutics. And how do you do that? Well, work with the subspecialist. It is his call to decide whether it should be tapered and whether it can be stopped. Only if that is agreed upon as a prerequisite can we go ahead with the next step. We will then like to change it over to 1 single dose per day, and we would like to use intermediate acting glucocorticoids rather than long acting glucocorticoids. The degree of tapering regimen will depend upon if it's a long-term glucocorticoid use. I would go very slow because these patients cannot
And as you know, there is a strong relationship between the pre-diabetes and diabetes, and the majority of people who present in our clinic with insulin resistance, with pre-diabetes, including IFG or IGT, have a higher risk of developing the disease, so type 2 diabetes. So the question is, how can we prevent the onset of diabetes in patients with a diagnosis of IGT or IFG? Next, please. Next, please. And there is the important, the last, if you can go back.
Sorry to interrupt you, Professor Napoli. Could you please increase the sound from your end, please?
Okay, so if you can go back to the last slide, to the previous one. Okay, so it's very important to know that even diabetes, even in pre-diabetes, there is a high risk, again, to develop diabetes, and mostly patients with IGT plus IFG have a 12 higher relative risk of developing diabetes. And the next one, you can observe also that pre-diabetes is an independent risk factor for developing cardiovascular disease and death. So this is very important because the majority of our patients in the clinic are not diabetic, but are pre-diabetic. And we don't see them in a diabetes clinic, usually. These are patients that are observed by GPs or by physicians who are engaged in obesity clinic. And it should not be forgotten again that the presence, the diagnosis of pre-diabetes increase the risk of cardiovascular events and death. So it's very important that we use all possible measures to prevent not only the onset of diabetes, but to revert the state of pre-diabetes and giving back to patients a normal glycemic status. The next, please. And again, this is the UK-PDS data showing that the beta decline, the beta cell mass decline is a continuum, but we can always work on insulin resistance, and we can mostly avoid through some indications that I will give you in the next slide, the onset of diabetes. So the next, please. Next. So what is the evidence that the type 2 diabetes can be prevented or delayed? Next. Okay, so now we can use three possible approaches: the diet, the exercise, and this means a lifestyle intervention, or medical treatment. And in this case, we will focus on metformin, and then we will give an overview on pioglitazone. So on medications that have proved to improve insulin sensitivity and glucose tolerance. So if we put a patient on diet, what is the chance that we prevent diabetes? And actually it's 34%, according to this data in China, is 60% actually in patients treated in the US or in Finland, and 30% in India. So it means that there is a kind of a trend for a different race, a different ethnicity group effect, because the diet is more effective in people who is in Europe or in the US than what we obtain in Asian people. So exercise, again, it's very important. So 40% reduction in general in in patients in China. And when we combine diet plus exercise in the US or in Europe, we obtain basically a 60% reduction in developing diabetes. How important is metformin? Metformin reduces the risk of developing diabetes by 30% in the DPP study in the US. And when we combine, and this is a study in India, the IDPP, metformin plus diet and exercise, the reduction is about, again, 30%. So if you look at the data from India, it doesn't seem that there is an increase in benefit adding exercise, diet plus metformin. So both lifestyle intervention and metformin play an important role, and the combination of them is important to prevent diabetes. If you go to the next. So what we know from the DPP trial, and these are data from US, that we can reduce 31% independently by metformin, 58% by using lifestyle intervention. So according to this data, it's important first lifestyle intervention, and then if not enough, we start metformin. But the first approach, the most effective one, is again lifestyle. Please go ahead. So the effect, of course, is important mostly in the first year, and the effect goes down according to the progression of the treatment. So it's very important to achieve a very important effect on body weight, on exercise, on improvement insulin sensitivity during the first year, because this will be, again, the effect will be slower and less in the next years. Please go ahead. And this is an overview of other medications. Some of them are not more available, like the rosiglitazone, but we have a very important effect played also by acarbose by 25%, by the pioglitazone in the Act Now by 72%. And the pioglitazone, I believe in this moment, with some problems, of course, with side effects, is the most effective on improving insulin sensitivity, and this may, again, result in the best possible effect on preventing diabetes. There are also data on the Origin study using glargine in patients with hyperglucose resistance, but I believe that giving insulin to pre-diabetic patients is totally useless and is not effective, and actually is riskful because of the risk of hypoglycemia. Next. So it's important to know that metformin, next please, has an efficacy that is overall improved in many. Next. Next slide. That is improved, the efficacy is improved in most of outcome, like in the A1C outcome, and you don't see a difference between basically many aspects like FPG or 2 hours fasting glucose in terms of A1C. There is a better effect in younger people than elderly people, and there is no difference in terms of gender between males and females. Next. And also in terms of FPG outcome. Next. Next one, please. Something very important is the next, please, is the effect of metformin on cardiovascular complications. There is no efficacy on MACE, on heart attack, or myocardial infarction, but there is a very important effect proved by metformin on intravascular calcification, on improving intravascular calcification. So this makes this medication still effective, not only on preventing diabetes, but also on preventing possible complications like cardiovascular calcification. Next. And now I would like to show you the data on pioglitazone. Next, please. With a strong effect, again, by 72% in reduction of diabetes onset in patients on pioglitazone. This is a very important study. Please go ahead. Next. And you can see here the effect is very strong in all possible range of patients, according to age, according to gender, to ethnic group. The effect is constantly improvement of glucose tolerance and insulin sensitivity in all possible patients. Go ahead. Next. But here we need to realize that there is a positive effect on glucose, there is a positive effect on A1C, and they are all positive. But there is a problem, there is an increase in body weight that's typical of pioglitazone, and this may be a problem. And there is also an improvement in the blood pressure. Next. Next one. And I would like to show you this last data on cardiovascular risk, because the data in with pioglitazone have proved that MACE are reduced, myocardial infarction is reduced, and stroke is reduced. So pioglitazone is a very effective medication on improving glucose tolerance, on reducing the risk of diabetes by 70%, improving MACE, so cardiovascular events. But again, there are two important side effects: body weight, blood cancer, and mostly in postmenopausal women, the risk of fractures. Therefore, pioglitazone should not be used in postmenopausal women and in all patients at risk of fracture. So I would like to emphasize that it is very important to prevent diabetes with lifestyle intervention. And when lifestyle intervention is not enough, we need to be very quick on putting the patient on treatment using either metformin or in case the patient is eligible, on pioglitazone. And there is a strong now amount of data proving that if we bring back patients to normal glucose tolerance, we have the higher chance to prevent diabetes, but mostly to prevent cardiovascular events. Thank you very much.
Sorry about the glitches. Thanks very much for the invitation. I'm Steve Davis. I'm a consultant endocrinologist based in Cardiff, and also director of the postgraduate diploma MSc courses that we run in conjunction with the University of South Wales. What I like to do is start with that which is relevant to the audience, and that being the case. That's what we always see. And what I want to try and do is interpret the evidence in relation to something that we see day in, day out. So I'm going to talk about hypogonadism and erectile dysfunction with regard to a patient, because it otherwise seems rather turgid and boring. So this patient was referred, he's a 52-year-old man of Asian descent with refractory, as it was described, erectile dysfunction. The GP notes that they treated him with sildenafil, but this was unsuccessful. 8-year history of type 2 diabetes associated with hypertension, for which he takes simvastatin, vitamin D, metformin, sitagliptin, amlodipine, and ramipril. So, of course, we're also looking at somebody with endothelial dysfunction as well as erectile dysfunction, because he's also got a vascular risk associated with hypertension. Latest HbA1c is 6.8%, which translates, for those in the audience, 50 millimoles per mole. So pretty reasonable control. And his blood pressure, 130/80. Again, pretty reasonable control, as referred to me by the general practitioner. Testosterone concentration is normal, and that's 8.8. And I'll discuss that as we go along. The most important thing, this is what I tell everybody, is take a good history and examination. 80% of what we can do for the patient in terms of making the diagnosis, the appropriate treatment strategy, understanding what's going on is in the history and examination. So what I've noted from this patient is that the erectile dysfunction has been going on for about 2 years. Libido is poor. This is all very relevant. So whilst there's a lot of words here, this is very relevant. But importantly, he's got a lack of interest in sexual function. So his libido is poor. His erectile dysfunction has been causing problems in his marriage because he's got a wife. His second marriage, his wife is 12 years younger. But he describes normal shaving frequency, normal body hair. Very little in the way of early morning erections. It's important to tease this out to determine what may be underlying his erectile dysfunction. And if he does have an erection, it's very poor quality. This is important, very important, because the GP has written that he's failed PD5 inhibitor therapy. Sildenafil, he's used about 10 times. Takes it just before attempting intercourse. That's about 10 minutes before. And he doesn't like it because the sildenafil really doesn't work. And he's on a dose of 50 milligrams, but it gives him a headache. So he's frustrated. He's a non-smoker. He's got type 2 diabetes under the community diabetes team. And importantly, the general practitioner switched him from bendrafluozide to amlodipine, which has made little difference in terms of what's important to him is erectile dysfunction. So the examination reveals that he's overweight with a BMI of 28.7, but there's central adiposity going on. Whilst we say, oh, you know, bit overweight, okay, this is contributory, but there's central adiposity with a waist circumference of 93 centimeters. He appears normally virilized, i.e., he's got normal body hair. He's euthyroid. This is important, and many people do not do it. Examine the external genitalia because we can begin to understand whether this is primary testicular failure, if he's got atrophic testes. And on this occasion, the testicular volumes were 12 mils bilaterally, which is normal. And importantly, examine the penis because Peyronie's disease is very common. About 10% of the population will suffer from Peyronie's disease as they get older. And that will contribute to erectile dysfunction. But there was no evidence of that. So the penis was normal. Blood pressure. He's got evidence of an early peripheral neuropathy with sensation absent and to the ankles, to vibration sensation, but as normal pulses with normal ABPI. Retinal screening showed a couple of microaneurysms. So we're already looking at somebody with endothelial dysfunction. Okay, that's the case. And microvascular complications. Testosterone there is 9 millimoles per liter, normal range being 8 to 30. That's described in our labs. Prolactin, important to check that, just in case we're dealing with a microprolactinoma. LH and FSH quoted within the normal range. Other parameters there are perfectly fine. So let's move on. We got the investigations that provide us with the information. And what we got is a normal testosterone, allegedly, with normal LH and FSH. Now, let's relate the evidence to this particular patient. We see and we know that erectile dysfunction is very common. You're going to see it in the vast majority of middle-aged men that are going to come to you. And right across countries, we're looking at, in particular, this group, look at the 50 to 59 age group here. We're looking at roughly 20 to 30% of those patients having erectile dysfunction. So that's the age group of our patient. And this cartoon really illustrates it very well from Family Guy. What we know is, as you can see with little Stewie there, the youngster, he's got a very impressive lightsaber, unlike the older man that's rather poor. So despite this comical sketch, we know that as we age, endothelial function deteriorates, there's a cumulative risk for erectile dysfunction. And whilst it appears funny, it's not so funny for the patients that suffer that problem. And that's in normal population. When we go to a diabetic population, which is an increasing problem and is the case in our particular patient, look at the blue bar here, which is the age 50 to 59 group. In those with a peripheral neuropathy, which is absent, we've already said that we're looking at about 40% of our patients in that age group that are going to have erectile dysfunction. When you add diabetes into that, in this patient with peripheral neuropathy, who's 52 in the 50 to 59 age group, we're looking at 70% of those patients having erectile dysfunction. Quite a stunning statistic when we incorporate diabetes. If the patients have autonomic neuropathy, then fundamentally 100% of them will have erectile dysfunction. And what are the causes of erectile dysfunction? Well, we kind of touched upon it, but it's usually a collection of problems, mostly vasculogenic, as we know, with erectile dysfunction being associated with endothelial dysfunction and vascular disease. But there are other factors that contribute, in particular pharmacologic. Benzoyl fluoride, thiazide diuretic, is certainly one of those agents that is heavily associated with erectile dysfunction, unlike things like amlodipine and ramipril, which are relatively neutral. And in fact, ACE inhibitors may have some positive effect with regard to erectile dysfunction, were we to look at the evidence. So it's usually a constellation of problems that contribute to erectile dysfunction in patients with diabetes. And is it laughable? Is it something you can just be flippant with? Well, no. Endothelial dysfunction is itself, erectile dysfunction is itself a cardiovascular risk factor, as indicated by this slide. Because if you do have severe erectile dysfunction, as illustrated by our patient, you're looking at a twofold increased cardiovascular mortality, roughly twofold increased cardiovascular mortality, which isn't far off that which we see in a diabetic population. So already, by the presence of erectile dysfunction, we're defining an individual that has got an elevated cardiovascular risk. So it's not comical. We need to take this problem seriously, as it represents a wider problem in terms of cardiovascular disease and risk. And I'll come on to that in a moment. So the other thing that I want to focus on is this normal testosterone and normal LH and FSH. Well, that's not the case, actually, because when you look at the literature, despite this illustrating that the patient has a normal testosterone, what we do know is that testosterone declines from about the age of 30 by about 10% per decade, such that by the age of 70, you're going to have a low testosterone concentration in the majority of patients. And what we do appreciate is that a low testosterone is defined in terms of the symptoms as well, as a testosterone below 10.4 nanomoles per liter, 300 nanograms per mil, if you want to translate it into another formula. And when we look at patients, this is why it's important to do a testicular examination. It can either be primary, due to testicular failure, low testosterone, elevated LH and FSH. That's not our patient. Okay, or it's secondary hypogonadotrophic hypogonadism, low testosterone, which we now accept, okay, despite the quoted normal ranges, low testosterone in this chap, because he's displaying symptoms as well, with his low libido, and a low or normal LH FSH. So when people talk about this, and this is why I like endocrinology, we say there's a low testosterone, but there's a normal LH and FSH. So that's not secondary hypogonadism. It's not secondary hypogonadism. Yes, it is, because the normal LH and FSH is inappropriately normal for that testosterone concentration. So this is what we're beginning to deal with here. And hypogonadism, just like erectile dysfunction, is far more common in association with type 2 diabetes. Again, let's just focus on the bars associated with our patient here so we can relate evidence to clinical practice. We're dealing with a 50 to 59-year-old, and we see that in type 2 diabetes, about 50% of those individuals, middle-aged men, will have hypogonadism with type 2 diabetes versus a much lower level here, about 15%. So it's nearly 4 times more common in type 2 diabetics. And if we look at the prevalence here, number of studies that I've tried to formulate with testosterone concentrations that are variable in terms of the definition of hypogonadism, but the prevalence of low testosterone is about 33 to 50%, as I showed you, as I've illustrated on that graph. And again, when we look at it, the origin of type 2 diabetes is hypogonadism is multifactorial as well. And if you don't have low testosterone concentration, then the survival over an 8-year period is the order of 75% in men over the age of 40 over an 8-year period, as illustrated here. And I'm sorry I can't use the laser pointer, as illustrated by that blue curve. Now contrast that with what we see with low testosterone concentration, i.e. levels below 250 nanograms per deciliter, which equates to about 8, okay? As illustrated in the green line here, the Kaplan-Meier curve shows a markedly reduced cardiovascular risk because many factors may contribute to that hypogonadism, including visceral adiposity, type 2 diabetes, okay? Weight loss can contribute to hypogonadism. So it's itself a bit of a surrogate marker for increased risk and reduced survival. Just like to talk about the causes of secondary hypogonadism, and that's related to our case. As I've explained previously, there is a decline in testosterone concentrations as we get older, which is cumulative. So the individuals over the age of 70 often do have hypogonadism. There's weight-related hypogonadism, which is becoming far more dominant. 20 odd years, 30 years ago when I started endocrinology, we hadn't really heard of weight-related hypogonadism, but it's become one of the most dominant causes so far. Anabolic steroids, frequently see that in the endocrine clinic. Kalaman syndrome, rather unusual. And of course, pituitary lesions as well. Now, in this particular case, we can relate evidence to this practice. Does this patient need a CT scan of his pituitary because we diagnose secondary hypogonadism? No. And the reason being is that when you look and refer to the literature, a number of studies have looked at testosterone concentrations as a surrogate marker. And individuals with a testosterone below 5 should merit, and normal or low LH and FSH merit pituitary imaging. Now, in this guy's case, we're dealing with a testosterone of 8 and 9. So evidence would suggest this is not going to be due to a pituitary lesion. And that's good because we've avoided unnecessary radiology in this patient. Okay, so what do we think? This is probably weight-related hypogonadism. Why? And here, look at the middle there. The visceral adiposity was something that I was commented upon on this particular patient. So the visceral adipocytes, what happens is that testosterone is itself aromatized. So in the in the middle orange bar, we can see that being increased aromatization of testosterone. To the pink bar at the top, increased estradiol. So what happens is that testosterone is aromatized to estradiol. Estradiol concentrations are marginally higher, okay? Not perceptibly, but marginally higher. In a male, those marginally elevated estradiol concentrations feed back at the anterior pituitary to result in decreased LH levels and pulse amplitude as well, as shown by that blue bar on the right there. That then, in turn, feed back and causes a reduction in testosterone concentration. So fundamentally, that's what we see. That's the cause for weight-related hypogonadism. So let's go on to the next slide. So in this patient, we're dealing with weight-related diabetes, hypogonadotrophic hypogonadism, and we've also got the peripheral neuropathy, which contributes in itself a neuropathic erectile dysfunction. So we've got two problems here. Treatment, primarily, as the GP undertook, it's PD5 inhibitor therapy, and they've revolutionized the treatment of erectile dysfunction. I'm not going to deal with vacuum pump. Now, what you find is that the evidence suggests we're looking at an improved, we're looking at about 80%. When PD5s are used appropriately, we're looking at about an 80% efficacy in males with erectile dysfunction. Common side effects, as we found in this patient's case, is headache. So that's 80%. What happens in patients with diabetes, the efficacy in individuals with diabetes? Well, that 80% declines to about, as you can see on the right bar, 83% efficacy in terms of good result, reduced down to about 63% when we're looking at diabetics, because the nature of the erectile dysfunction is multifactorial, not purely vasculogenic. Okay, so again, the poor individuals with diabetes have a worse outcome. This is important because we're dealing with individuals who've got high cardiovascular risk. It's important that if we're going to treat a patient with erectile dysfunction with PD5 inhibitors, then we undertake a screening process. And if they are low risk, then we don't have a problem. If they're moderate, intermediate to high risk, we need to do a cardiovascular investigation prior to starting PD5s. Why is this important? Again, this is not comical, but Officer Hernandez, this is reported in USA Today, a bit of a salacious sort of report, very interesting and newsworthy. This Officer Hernandez, who was 40 years old, died in his police car in a three-way romp with a lady that wasn't his wife. His wife successfully sued the prescriber who gave him sildenafil, Viagra, because he had not undertaken a vascular assessment on him. And she successfully sued the prescriber for $3 million. So this is why it's so important to actually take the cardiovascular, to inquire about cardiovascular risk as well. So in this patient, the query is, has his PD5 inhibitor therapy failed? Because if it has, we've got to go on to secondary treatments. And this is the definition of it: inability to maintain or retain an erection suitable for sexual intercourse on at least 4 consecutive occasions with an optimum dose. So the 50 milligrams is not optimized, for one, because it's 100 milligrams of the optimal dose. And it's about right timing, right stimulation. So if the World Cup rugby is on at the moment, Wales are unfortunately out. But if someone wants to have an erection while watching the rugby on TV, that's not going to happen. That's not the right stimulation. So it's about right timing, right stimulation, right dosing. He needs to take it at least 30 minutes before anticipated sexual activity. Well, he was taking it almost at the point of sexual activity and then becoming frustrated. So that's not appropriate either. So it's about educating the patient with regard to the use of PD5 inhibitor therapy, because the results can be outstanding with that treatment. Second line treatment, I just briefly mentioned it, intracavernosal alprostadil is a useful treatment for those individuals that will fail, that 20% that will fail, which is roughly 40% in patients with diabetes, as we've previously described. So that's what I've noted there, because don't just stop at the PD5 inhibitor therapy. Consider treatment with the second line, i.e. intracavernosal injections, which itself is associated with about an 80% success rate. And personally, I find that better than the intraurethral alprostadil. Requires a degree of training, and patients are taught how to inject into the penis, but it's very straightforward and painless. So in this particular patient, however, we're looking at also a problem with hypogonadism. And if patients have got hypogonadism and erectile dysfunction, and diabetes and erectile dysfunction, and they don't have that sexual drive, the libido, then you've got a bit of a problem. You've got to change the libido, because otherwise PDE5 inhibitor therapy won't work. So what we need to do in this patient is treat with testosterone as well, okay? And after a discussion, the best approach for him, as far as he was concerned, was topical testosterone. And this is the interesting thing. Testosterone and PDE5 inhibitor therapy, when combined, and when we look at this, before treatment, the erectile function index, as measured here by IIEF5, showed that before treatment in this patient group, their measurements of erectile function very low. After treatment, we can expect to see an effect by about 6 months with improved libido and PDE5 inhibitor therapy. So what's the progress report in our chap here? Treated with testosterone in the first instance, topical testosterone, reviewed at 3 months. We're measuring his HP and PSA to make sure that it's adequate. Libido was much improved, some poorly maintained erections, and then we go for the addition of PDE5 inhibitor therapy. And to a certain extent, they're all pretty much the same, but it's about instructing the patient on what may be better for them and responding to their requirements, I guess, in terms of sexual activity. So we started on a dose of 10 milligrams of tadalafil, reduced side effects mostly with that. And he did very well. So his testosterone, as we measured, was 17.7. PSA is unchanged. Erections were much improved then, with a optimization of dose to 20 milligrams of tadalafil. And for him, he came in a different person. This is purely because of taking the history and doing an adequate examination and then treating appropriately based upon evidence. So he was able to have successful penetrative sex. 6 months later, he's very happy with the result. And he's back to his GP for annual checkup. So in conclusion, erectile dysfunction and hypogonadism are an increasingly problem in an aging diabetic and heavier population, associated with major psychological and physical morbidity, and of course, mortality. Treatments are effective, safe, and synergistic, but need to be optimized. It needs to be discussed with the patient, and treatments need to be monitored. Thank you very much.
Thank you so much, Professor, for the wonderful presentation. Now we would like to take one question from the audience for you.
Thank you, Prof. Davis, for the very great presentation. I am Sarah Firdausa from Indonesia. I would like to ask you about one patient with low testosterone but normal LH-FSH, but then he has morning erectile, but he cannot get well with his partner. So can we directly proceed to testosterone treatment, or previously he has diabetes, which was goodly controlled with HbA1c at 4.6%, and everything is well. Cholesterol is lipid profile is also in the good range. The problem is only in his testosterone was in low. It's about, if I'm not mistaken, 12 something, and normal LH-FSH. So my question is, what should we do? Should we proceed to diagnostic, or we can directly go to the treatment? Thank you.
Righto. Okay, it depends upon his symptoms as well, and the symptoms are very important. The history is so relevant here with regard to any suggestion of low libido, which would implicate low testosterone. You said the testosterone was 12 as far as 12 nanomoles per liter, I guess. Isn't particularly low, but individuals below 15 with symptoms, we might measure their free testosterone concentration or bioavailable testosterone to get an idea of what their bioavailable testosterone is, and then potentially consider a trial of testosterone. Did you suggest that this person was looking for conception as well?
He never used any conception.
No? Sorry, I can't hear you that well.
Yes, yes. He
Yeah.
tried to conceive.
He's trying to, so he's trying to conceive. Now, actually, you're making it a lot more complex for me now. But there is evidence that actually you can combine testosterone with HCG preparations as well, okay? Until you get the HCG going to the appropriate level, if you think this patient has got hypogonadotrophic hypergonadism. But one of the starters, the way I would start it is having a discussion with him saying that if it's testosterone on its own, then that's not going to actually help with conception, but it may give us an idea of whether this patient has got a degree of hypogonadism. I would measure his bioavailable testosterone, okay, which is a free testosterone, really difficult to measure, but bioavailable testosterone can be calculated from total testosterone, including the albumin and sex hormone binding globulin. So it makes it often easier to do. I hope that helps. Maybe not much, but it may help a little.
Yeah, sure. Thank you so much for your great answer.
Okay, my pleasure.
Thank you so much,
everybody.
Professor Steve. It was nice having you on the podium.
Yeah, my pleasure. Thank you very much for the invitation.
Hi, good afternoon. Thank you for inviting me. Let me just quickly see how I can change the slides myself or not. I may have to ask you to move the slides for me. Thank you. So, as you mentioned, I'll talk to you today about the various presentations of acute presentation of neuroendocrine tumors and how to approach the initial diagnosis and the treatment. Next slide, please. I have no conflict of interest with regards to this talk. Next slide, please. So I wanted to start with a brief overview of what neuroendocrine tumors are. As the name indicates, they originate from neuroendocrine cells that can be found in various parts in our bodies, particularly in the GI tract and the pancreas. The interesting things about these tumors is that the cells have the ability to synthesize, store, and release various peptide hormones, and that leads to how these patients often present with various symptoms and syndromes. As I said, most of those tumors will occur either in the GI tract or the pancreas, but about 25% will occur in the lung as well. Very rarely will have breast, thymus, prostate, or the skin involved. More than half of them are called carcinoids, located in various parts of the gut, and followed by pancreatic islet cell tumors. The important thing to note about those tumors is that they often express somatostatin receptors on their surface, which is useful from the diagnosis and management point of view. And we'll talk about it briefly soon. Next slide, please. So NETs are typically slow-growing tumors. In the UK, we have about 4,000 people diagnosed with them each year, with the average age of presentation in the 50s and 60s. But the problem in our country, and I guess worldwide as well, is that there is quite a significant delay from the first symptoms onset to the diagnosis. It's more than 4 years. And people on average see about 6 healthcare professionals before the diagnosis is made. And that is because the initial symptoms can be quite generic and a little bit misleading. And sadly, about 1 in 5 patients at the time of diagnosis will already be found to have metastases. Next slide, please. So this is how WHO grades the NETs. So it all depends on the proliferation rate. And we've got low-grade tumors, grade 1, then intermediate and high-grade tumors with high proliferation rates. And those are termed as carcinomas. Next slide, please. So how can they present? Today, I'm going to focus on medical presentations mostly, as I presume mostly medics in the audience today. But these patients can come on the surgical take as well, and they can be quite poorly with bowel obstruction, biliary obstruction, or mesenteric ischemia. From the medical presentations point of view, most of these patients will come with some sort of hormone hypersecretion syndromes, like carcinate syndrome, insulinoma, pheochromocytoma. And those NETs that do secrete hormones are called functioning. However, most of them will be non-functional, which means that they do not produce biologically active hormones. And as I said, because of the fact that this presentation can be a little bit difficult to pinpoint, these patients often get misdiagnoses: inflammatory bowel disease or irritable bowel syndrome, gastritis, asthma, menopause, or anxiety, some other psychiatric problems. Next slide, please. And this is because the first complaint they may report is something that can have various different explanations, as you see in the GI tract. It could be abdominal pain, diarrhea, GI bleed, a bit of flushing, and similarly with the bronchopulmonary ones, cough, hemoptysis, or recurrent infections. These are symptoms that we see day in and out on our medical takes, and they can have so many different explanations as well. Next slide, please. So I thought we're going to go through a few cases just to highlight a few things and important approaches to diagnosis and initial management. And these were all patients that we dealt with in our center. So we're going to start with the 57-year-old man who previously was completely fit and well. And the only thing that you could pick on in his medical history was that he maybe drank a little bit excessively, 10 units of alcohol per week. And he was admitted to our A&E department following a tonic-clonic seizure that was witnessed by his partner. He apparently fell to the floor, had the seizure, then was completely confused and unaware what happened to him, could not recall it at all. And when we looked on our computer system, like, does he have any past medical history? The only thing we could see was that there was an online referral sent by his GP to the cardiology department quite recently, because he apparently had 4 syncopal episodes in the last 3 months. So the opinion was sought from the cardiology colleague, is there something going on with the electrics in his heart? Next slide, please. But looking at the information from the ambulance crew, he actually had a BM of 2.1 when the paramedics arrived, and that was treated accordingly. So by the time he got to A&E, his physical examination was unremarkable, CT head was normal, and the bloods, including lactate, pH, were all fine as well, and the glucose was stable at 4.8. But because of this unexplained blood glucose, endocrine consultation was asked for, and insulinoma was suspected. Therefore, 72-hour fasting was started. And the following morning, he already dropped his blood glucose to 1.7 in the early hours of the morning. And it is actually quite important to remember that these patients will often have morning hypos, early morning hypos. And sometimes it can just present as early morning confusion. They're just not feeling well. They may have a bit of headache and nausea. So even though the hypos are something that we all like to believe that we're very familiar with, it is important to take the history properly and think about it, because it's easy to miss such presentation or to explain it with something else. Next slide, please. So as he dropped his blood glucose, the relevant bloods were sent off for C-peptide and insulin, and you can see they were actually sky high in this patient. He also had fasting gut profile sent off, NFA and 3-hydroxybutyrate, which were normal. And then we send a sulfonylurea screen, which should be a standard thing when you deal with patients like that, just to make sure that there's no malicious use of sulfonylureas. But unfortunately, in this case, we never got the result because it was sent in the wrong bottle, and just shows that it's really important to give proper directions to the staff who's sending those samples to make sure you get the result. Next slide, please. So for the symptom management, this gentleman was started on diazoxide, which stops his hypos and works by reducing the insulin secretion from the pancreas by working on the potassium ATP channels. And we followed him up with the radiology. Unfortunately, both CT and MRIs have shown that he's got quite a large mass in the body of the pancreas, and at this point there are already bilobar liver metastases, which, as we discussed a few minutes before, he is in that 20% of people who already present with metastases at the first presentation. The liver biopsy confirmed that it was a well-differentiated grade 2 NET, and we did a gallium dotatate scan on him, and I'm gonna explain to you about the scan a little bit later on what it is, but it showed that he's got avid pancreatic dotatate positive tumors in the liver. So while he was waiting for the bulking surgery, the octreotide was started, and the somatostatin analogs are actually the cornerstone of the treatment of the neuroendocrine tumors. So they are useful for symptom control, but they also help with overall progression-free survival, and they've got some anti-proliferative effect on the tumors as well. Next slide, please. So let's talk about the insulinomas as such. So these tumors are not common. It's about 1 to 2 per million of population, and they cause hypoglycemia by inappropriate insulin secretion. Most of them would be benign and solitary. About 1 in 10 will be associated with MEN1, so it's important to think about that as well. And the symptoms are classic presentation of hypo. So you can have adrenergic symptoms like pallor or sweating or tremors or tachy, and neuroglycopenic symptoms such as confusion, altered behavior, aggression, and in most extreme cases, seizure and coma. And these symptoms get resolved by carbohydrate consumption. And also because of that, it is quite common that these patients will present with weight gain over time, about 1/3 of them. Next slide, please. So I wanted to highlight to you how important it is to biochemically investigate those patients properly before you go on and request radiology. And the gold standard test is 72-hour fasting. And you do it until the blood glucose drops below 2.2 in association with an appropriate high insulin C-peptide, then you've got your diagnosis. Practicality is about doing this test. So you admit the patients to your ward, and you start fasting them and measure the blood glucose every 6 hours until it drops to less than 3.3. And following that, your blood glucose monitoring should increase to 1 to 2 hours. And you should only end it if the venous blood glucose is less than 2.5 and people have signs of hypo. So basically, you need to make sure that once the capillary glucose is low, the sample from the vein is sent off ASAP and the lab confirms it, so you can terminate the test, because otherwise you may end up repeating it. And after that, you treat the hypo. So you give them the short-acting carbohydrate and then follow the long-acting carbohydrate, but you have to make sure that you measure blood glucose very carefully every 10 minutes until it goes up, and then carefully over the next 6 hours just to make sure they have another hypoglycemia. So it is important to put clear instructions in the notes for the doctors and for the nurses, because it is quite tricky to resist the temptation to treat the blood glucose once it starts dropping, or patient may start feeling a little bit symptomatic. In this case, you really have to persevere. So these people need close monitoring. Next slide, please. Management of insulinoma. So the management of choice is we want to localize the tumor and then remove it surgically. For the treatment control, as I mentioned before, it will be diazoxide plus minus octreotide. If you have a solitary insulinoma, that will restore your life expectancy to normal. Obviously, it's slightly different when the metastasis happen. Next slide, please. So here's another case that we were involved with. There was a 19-year-old girl that was admitted to one of the rural hospitals in Wales in the middle of one of the COVID waves during the pandemic. This girl had a past medical history of type 1 diabetes since she was a baby, and she was on basal bolus insulin, and she was admitted with a hypo. Blood glucose was 2.7. And initially her observations were fine, apart from the fact that she was quite tachycardic, around 125, 128 beats per minute. The examination revealed there is some bronchial breathing at the left base, but otherwise heart sounds were normal, abdomen was soft, non-tender, and the bloods on admission were actually quite unremarkable. There were no increases in inflammatory markers, her kidney function was fine, even lactate, ketones and glucose were fine as well. There was a bit of haziness in the chest x-ray. ECG showed sinus tachy. She was observed in the A&E shortly after the admission, and then suddenly she developed an SVT and needed to have adenosine and magnesium infusion, and then rapidly deteriorated to a peri-RS state with SATs going down to 70% and her ABG deteriorating quite significantly. Obviously, it was middle of the pandemic. Everybody thought, is it COVID? And she has PE. Nobody thought about endocrine causes of the deterioration at that point. Next slide, please. So CTPA was done, and there was no evidence of any PE. However, she had bilateral alveolar shadowing, and the radiologist said that's either bilateral pneumonitis or massive pulmonary edema. Her D-dimer went up, her troponin went up, but the COVID swabs kept coming negative. And she had some micro workups as well towards strep and Legionella, they were negative as well. So at this point, cardiology consultant was asked for consultation. The echo was done, and it showed that her LVF is actually 30 to 35%. So the initial working diagnosis was that she probably has got some sort of infective myocarditis, but it was all a little bit unusual. And this case basically illustrates that it's quite important actually to get more history, as much history as you can, as much information about the patient as you can, because then this doctor went to look through her notes, and he had seen that actually quite recently, literally, with a happy coincidence, a lucky coincidence as well, she was seen in an endocrine clinic because there was a history of pheochromocytoma in her family, and there are family members that had SDHB mutation. And she was just seen in an endocrine clinic, had her genetic screening sent off, and the plasma and metanephrines which were pending. So that changed actually the approach. It was that now that we had a strong suspicion that this could be pheochromocytoma crisis, and because this lady developed high blood pressure as well, at that point, her treatment was switched to phenoxybenzamine. And gradually she started to improve, and a few days later, she was extubated. Next slide, please. So in the meantime, they managed to chase the plasma metanephrine results and showed that normetanephrine was really, really high. Her dose of phenoxybenzamine was up titrated, and then beta blockers were introduced as well. And radiology was performed, and it showed that she's got a large 5.4 centimeters paravertebral mass at the T2, T3 level, which is consistent with paraganglioma. Next slide, please. So she was transferred to our center for the excision of this mass. Unfortunately, she developed post-DKA. Her SDHB mutation came back positive as well, which was in keeping that with the fact that her father and her sister already have it as well. But luckily, the follow-up MRIs show no recurrence, and the follow-up metanephrine monitorings are fine, but she will stay as similar to her family under lifelong surveillance. Next slide, please. And this is a similar case, but different, highlights slightly different issues. So in the first pheochromocytoma paraganglioma case, we have the importance of taking history. And here we're going to discuss the importance of trying to figure out what we should do with the borderline biochemical result. So we referred a patient in his late 40s who had slightly difficult to control hypertension. He was on doxazosin, amlodipine, perindopril, slightly high BMI, but maybe not so as per today's standards. And he recently had DVT, that's why he was on the warfarin. And the GP struggled to manage his blood pressure, and he was worried that this patient had episodic palpitations, felt lightheaded from time to time and sweaty, and that was occurring about twice a week without any warning, often associated with the time when that he was standing upright. The spontaneous recovery always followed. In this case, there was no family history of any endocrine disease at all, and there was nothing much on his examination apart from obesity. Next slide, please. So obviously, when he comes to the endocrine clinic, we look for other secondary endocrine causes of the high blood pressure. But as I said, he didn't look Cushing on examination. His cortisol workup for urinary free cortisol and dexamethasone suppression tests were fine. He had normal urinary 5-GAAs, normal chromogranins, but the urine noradrenalines were elevated on few occasions. And sometimes they were only a little bit elevated, around 9.37, sometimes up to 21.09 micromolars per 24 hours. And our normal is less than 4. So they were repeated a few times after stopping interfering medications, because we're trying to figure out, is it significant or not, that raise in noradrenalines. And next slide, please. The reason why we were repeating it so many times is because we couldn't really find where it might be coming from. So there was nothing in his adrenal glands. There was no obvious paraganglioma in his neck or in his around his T-spine, and the CT thorax and abdomen and pelvis showed that the only abnormality was a tiny 2.6 centimeter nodule on the right side behind the bladder by the seminal vesicle. So that's the imaging from the CT. Next slide, please. And it was also seen on the MRI. But when we investigate neuroendocrine tumors, we want to have some evidence that these lesions may be active from the functional imaging. But the MIBG scan in that region was absolutely normal. So we had a bit of a dilemma. And then we decided to send this patient to London for a dot-dot scan. Next slide, please. And surprisingly, or maybe not surprisingly, this lesion actually in the seminal vesicle was glowing, so suggesting that there is that's probably the source of this increased normotenone production. Next slide, please. So we discussed him in the MDT. If you maybe could play the video for us, he ended up to have robotic surgery following the appropriate alpha blockade. And the reason why we went for robotic surgery is because of the location of the tumor. It wasn't such a difficult to access place that if we had open surgery, that the recovery would be really, really long. Probably the video is not playing properly. I'm sorry about that. Next slide, please. But the histology did confirm that there was indeed a paranganglioma. And luckily, the gentleman post-op has recovered. All his metanephrines are coming normal. And the genetic analysis did not reveal any mutations. So it was completely a spontaneous tumor in such an unusual location. And actually, there are not that many of these seminal vesicles paragangliomas reported in literature, literally maybe 10 case reported. So it was extremely rare. And this case basically highlights that when you have a suspicion, sometimes when the symptoms may be a little bit vague and the biochemistry is a bit borderline, you need to persevere with trying to find the right imaging modality. And in this case, the dot-dot scans actually proved to be very good, but they're not easily accessible in all the centers. Next slide, please. So what are pheochromocytomas and paragangliomas? So pheos are adenomedullary cadherin secreting tumors, whilst paragangliomas are arising from extra adrenal tissues. And they can be found around in the carotid body, druid and panning areas, aortic pulmonary, but also in unusual location, like you could see in this case we just had. They actually account for less than 0.1% of causes of hypertension, but us as endocrinologists, we're a little bit skewed and we actually screen for them quite a lot. And probably that's why we see a little bit more as well. And they can be associated with various genetic conditions like MEN2A and B, von Hippel-Lambda, or neurofibromatosis. Sporadic tumors are usually unilateral and less than 10 centimeters, and familiar syndromes that can be bilateral. And about 50 to 20% of them are malignant, a bit more often with paragangliomas, and metastases usually occur locally to retroperitoneum, lymph nodes, or mediastinum. Next slide, please. So when should you be thinking about it? There are various clinical features that may suggest that patients have this problem. This will be episodic hypertension, which is resistant to conventional therapy, episodes of sweating and heat intolerance, of flashing or pallor, even pyrexia sometimes, headaches, paresthesia, some visual disturbances. People can have palpitations or chest pain, breathlessness. There could be postural drops in the blood pressure, or just simple abdominal pain, a bit of nausea. And in the more extreme cases, people can have LVF, dilated cardiomyopathy, pulmonary edema, like in our young patient, hypertensive encephalopathy. So in hindsight, it all looks obviously always obvious when we make the diagnosis, but sometimes, as you can see, the symptoms can be so generic that it's so easy to explain it with other things as well. Next slide, please. Things that precipitate the pheochromatoma crisis is often straining, exercise, and put pressure on the abdomen, surgery as well. That's when you need to alpha blockade them, and certain medication. Next slide, please. But once you suspect that people have this problem, you need to do biochemical screening. So first one will be 24-hour meta-analysis, unless you've got plasma assay available, but this is a little bit less commonly available. So many places still do 24-hour urine mets. And you should be doing that when you have somebody with hypertension and episodic symptoms of acatylamine excess. When you have a young person, less than 40 years, who's got treatment-resistant hypertension. And obviously, when you find an incidentaloma in the adrenal gland, which is actually very common these days, and we get lots of referrals of that. You should be sending off the screening for metadrenalins. Obviously, those with genetic predisposition, like our patient with SHB mutation, and once you treated the patient surgically, you assess them for recurrence, so you do them as well regularly. Important thing to note from the interpretation of the biochemistry is that if you only have noradrenaline raised, that suggests that it could be an extra-adrenal pheos or paranganglioma. If both are raised, normed and metadrenaline, then that suggests that this is an adrenal pheo. Next slide, please. Important thing to note is lots of people will be on polypharmacy these days. So when you have a result which is not quite as high as you would expect, it's less than 2 upper ranges of normal, it could be a false positive. So it's important to look at the medications, make sure there's nothing interfering, and repeat of that medication if it's safe to withdraw it with the patients. And there are also various dietary things like caffeine, bananas, pineapples, walnuts that can affect the results. So you also should advise the patients to avoid consumption of these products while they're having the 24 urine collections done. Next slide, please. With regard to management, you need to prepare patients for the surgery with alpha blockade and beta blockade, and that also is the same when it comes to contrast procedures and smaller procedures. So you usually start phenoxybenzamine, 10 milligrams twice daily, and increase it gradually. But if it's not available, doxazosin will exactly do the same job, so you can easily use it and start in small doses like 2 to 4 milligrams BD and up titrate. After 2 to 3 days, we add beta blockers such as propranolol if required. Our goal is that the blood pressure when patients are sitting is 130/80 or less, and 100 millimeters of mercury when they're standing, and the pulse is 60 to 70 sitting, 70 to 80 beats per minute when they're standing. And people will typically report that they have got nasal stuffiness when the alpha blockade works. So that would be one of the symptoms you ask them about when you check. Sometimes in more extreme cases, we need to use pre-op IV phenoxybenzamine to prepare the patients. Next slide, please. So I will briefly talk about a few other nets, just to give you an idea what to think about, what to look for. Next slide, please. So carcinoid, these are the serotonin secreting tumors. And the incidence is only 2.5 per 100,000, but again, you don't want to miss these kind of presentations. Most of them are developed in the GI tract, but can also occur in the lung and some other organs like the thymus or the ovary. Some of them will be multiple, and they can be associated with other cancers like prostate, CEO, adenocarcinoma in the GI tract. Next slide, please. So carcinoid syndrome is something to be aware of. It only occurs in a subset of patients, and usually when the carcinoid metastasizes to the liver. But with regards to bronchial carcinoids, they don't have to metastasize, and people will still have features of the syndrome. So the most classic one is the flushing, which usually involves the face and upper thorax, a quite distinctive thing when you take the history, and it can precipitate with various foods, exercise, or postular changes. People can have diarrhea, asthma-like symptoms, pellagra skin lesions. Obviously, because of the tumor mass effect, there can be intestinal obstruction. And something to remember is the carcinoid heart disease, which will occur in 2/3 of those patients, with the right heart being typically involved in the pulmonary and tricuspid valves, and often requires surgical intervention, but this always carries high mortality and morbidity. Next slide, please. So when you want to diagnose, your first test will be 24-unit 5-HIAI, which is 100% specific and 70% sensitive. Again, you have to be aware about some dietary interferences from bananas, avocados, tomatoes, walnuts, and pineapples. You can do chromogranins as well, but won't give you that much answer. Plasma gut hormone profile might be useful. Important thing to notice that even though people may have extensive metastatic disease from this condition, often the LFTs will still be normal. So don't get falsely reassured by doing them. And again, as with many things in endocrinology, think about other associated symptoms that these patients can have. So always dig a little bit deeper into the medical history. Next slide, please. So how do we manage as with all the NETs, management of choice is surgery. We use somatostatin analogs. People may need hepatic embolization, chemo, or radioactive isotope therapy. Next slide, please. Similar to FEO, often it is important to prep them preoperatively, because these patients can have very low blood pressure, ranging from hypo to hypertension, bronchospasm, and carcinoid crisis. And that can actually mimic an anaphylactic attack, but then when you give the epinephrine, it will make things even worse. And especially patients who have carcinoid heart disease and those who've got very high 5-HIAs from the biochemistry, they are at risk of having a carcinoid crisis. So you want to give them IV octreotide preoperatively 12 hours before, and then continue for 2 days afterwards. And your anesthetic department should have the protocols how to use it, or if not, it's available in the literature online. Next slide, please. Glucagonomas are very, very rare tumors, but unfortunately, by the time patients present, most of them will have mets to lymph nodes or the liver. They've got classical signs of the necrotic migratory erythema, which starts in the groin and then migrates to limbs, buttocks, and perineum. People often have the mucous membranes involved as well. Not surprisingly, they can have diabetes or glucose intolerance, and they've got weight loss from protein catabolism, and often they're quite anemic as well, and they can have venous thrombosis. So next slide, please. And this slide just shows you how the erythema looks like in these patients, the mucosal changes. Next slide, please. So with regards to biochemical investigations, we have raised plasma glucagon. You want to do some gut hormone profiles as well, because the PP can be increased, and obviously you assess the glucose metabolism. And similar to other tumors, surgery is our first port of call. You may need some somatostatin analogs initially to manage them as well with. Next slide, please. Vipoma, they present with refractory watery diarrhea and hypokalemia and metabolic acidosis. Often they can be quite difficult to diagnose as well, because there are lots of other causes that can be more common for watery diarrhea, especially infective ones like E. coli or cholera. So you have to have quite high index of suspicion to think about these lesions, and often may happen that actually they get diagnosed after the patient already had a CT abdomen and the lesion is found. And then you proceed with the biochemistry slightly the other way around, as you would normally. And you would expect to see quite high levels of VIP from the fasting plasma, fasting gut profile. But bear in mind that can be also false positive in dehydrated patients. Next slide, please. So they usually originate from the pancreas, but it can happen. They can be found in other places as well, like small bowel, colon, kidney, or esophagus. Obviously, when you manage them, you want to replace the electrolytes in the fluids. Then, once they stable, proceed to surgery, and again, somatostatin analogs. They need chemo or hepatic artery embolization, depending how advanced things are. Next slide, please. Very rare tumors, somatostatinoma. You may not see them in your practice. I don't think I have ever seen a case myself. They usually originate from pancreas or duodenum. Again, diagnosed quite late when the metastases already occur, and these patients have diabetes or glucose intolerance, often gallstones, diarrhea, weight loss, and you will find somatostatin levels to be elevated in these patients. And treatment is, again, first line. You would want to go for surgery. Next slide, please. So a bit of practical note about checking the fasting gut hormone profile. So when you request that, you have to tell the patients they need to be fasted from midnight. They can have sips of water and the usual medication, but the ranitidine needs to be stopped for 72 hours and the PPIs for 2 weeks. Otherwise, you get false positive results. You need 1 lithium heparin and 3 EDTA tubes for this test, but they have to be immediately centrifuged and frozen. So that's why it's often difficult to do these tests in the community unless you have access to the freezer and the centrifuge. So most commonly, these people have to come to the hospital to have these done. It is not a GP thing to sort out. Next slide, please. I just briefly mentioned ICTHomas. They usually originate from the lung nets, and these patients present like Cushing's patients. but the presentation can be much more rapid and severe. So they will have your classic Fadry distribution, facial plethora, stretch marks, bruising, proximal myopathy, and you would proceed with normal testing as you would whenever you suspect cortisol excess with the immunosuppression test, salivary cortisol or urine cortisols, with conjunction with ACTH, which usually is quite high in this patients, and you would expect that they will have the range glucose metabolism. And often they may be a little bit difficult to find and can happen in unusual locations. So you often need functional imaging in addition to conventional imaging. Next slide, please. So I want to go back to this dot scan that we used for some of our patients. This is quite a novel imaging option, but it's quite informative. So basically, in the scanning modality, the dot-coupled somatostatin agonists are labeled with gallium, and the binding of the tracer and retention of the tracer depends on the density of somatostatin receptors on the cell surface and how much they internalize, and that's how why the lesions lit up on the scan. It's actually quite a safe scan with low toxicity risk, and it's particularly useful when you have negative imaging but positive biochemistry, or you keep getting negative imaging but you really have strong index of suspicion that there is something going on. So we're actually using it more and more recently, but unfortunately it's not available in our center. If we wanted, we have to send patients to London for that. So that always delays things a little bit fast from the diagnostic point of view, but this is much more sensitive than Octrio scan. Next slide, please. I would like to also mention PRRT, peptide receptor radionuclide therapy, which is again a novel treatment for people with NETs. And this is like IV radiotherapy, basically. So we have radioactive substances. In the UK, we use lutetium that is conjugated with somatostatin analogs and binds to neuroendocrine tumor cells. Those cells obviously that express the somatostatin receptors. And people are given about 4 doses of this treatment 2 to 3 months apart. And it's indicated for people who have NETs from GI tract or the pancreas that cannot be fully resected or they've spread to other organs. But obviously, before that treatment is given, we have to have confirmation that those people definitely have NETs that expresses SST receptors. So we usually have the gallium scan done first, and then they can travel to have this treatment. And again, it's only available in London for us, so we don't do it in our center as yet. Main side effects, nausea, vomiting, sometimes kidney inflammation, so they need amino acid infusion for renal protection. Sometimes pain from the tumor side can occur as well, but usually it's quite well tolerated by the patients and improves the prognosis. Next slide, please. And I just wanted to briefly mention a few other drugs that probably you're familiar with for other indications, but we are using them for NETs at the moment as well. So this is sunitinib, the tyrosine kinase inhibitor that inhibits angiogenesis, and it's licensed for progressive pancreatic NETs that cannot be removed by operation, and it improves people's overall survival and PFR. And everolimus, the mTOR inhibitor, that again works on cell proliferation, angiogenesis, and metabolism, and it is licensed for progressive metastatic NETs that cannot be removed. So we've got more and more options available for these patients, and novel therapies keep coming, and that can affect people's quality of life and the prognosis. Next slide, please. So the take-home messages from the talk are really that NETs can be either asymptomatic or quite challenging to diagnose. It's not always the classic presentations that we read in the textbooks and we immediately know, oh, it's carcinoid or insulinoma. It can be quite tricky. So especially when things do not adapt, think it's outside the box and think about these conditions, and hopefully following this talk you will know how to start the initial biochemical investigation to get the ball rolling. Remember how important family history is in these scenarios, and obviously in the setting of any it's not possible to do it very promptly, but always ask if you have any suspicion, because you may get lots of useful information from them. And because newer imaging techniques and management options are available, we've got more and more to offer to these patients. So this is quite exciting area of endocrinology, and hopefully you will be hearing more and more about it in the near future. Thank you very much. Next slide. Thanks for your attention.
Thank you very much, Dr. Vishak. My name is Alex. I'm from Indonesia. We found one case of insulinoma in Indonesia, but because of the limitation, we don't have any diazoxide. We only have the octreotide, but it's not octreotide LIR. Is it okay?
Yeah.
The patient, thankfully, is safe now after he underwent the operation, but we only had the octreotide but not LR. Is it okay?
That's not the problem. Any of them is fine. So it's about the frequency of injection. So you can use that just normal octreotide as well, yeah. And it the hypos should settle. And then I presume he has got no metastases, or does he have metastases, or are you just working him up still?
We don't do the surveillance because we don't have any PET scan in Padang because it's too far from the capital of Indonesia. So many limitations in our city.
Yeah.
But
so for symptoms control, definitely you can use octreotide, whichever one you've got available. But yeah, it will be worth trying to get the imaging, because if he's got a solitary tumor, then when you remove it, then you treated him and he has got the life expectancy back to normal. So I would definitely try to explore this option to see where the tumor is and if you can get it out basically for him. Yeah.
Okay. Thank you very much, doctor.
Yeah.
Great. Thank you. I saw one more hand raised. Yeah. We could have another question maybe before we move on to the panel discussion.
Thank you very much, Doctor, for the wonderful presentation. I won't actually ask the parts I understood very well. I'm Sheku Dennis Masakoi from Sierra Leone, Merck Foundation alumni.
Yeah.
My question basically is, as we've seen from the exhaustive presentation, basically they belong to the cascade of hereditary cancer syndrome. Okay? So as we can look further, you need to first identify the tumor. You have to at least know it, and then you stage it before treating. So what I'm saying, or my question is, are there any room for identifying the specific genes that are involved in each of these cases that you've presented? And then...
Well, we usually do genes at the end. So we usually start with biochemistry when you have the clinical suspicion, because if you do radiology first, you may find that there is a tumor somewhere in the pancreas or in the bowel, but it may be non-functional, something completely different on histology as well. So we want to have biochemical evidence there is something going on. That's why you do those tests that I mentioned. Then you do radiology, then when you need biopsy, and then you treat with surgery if you need to. And then once we have all the histology, we know what we're dealing with, then we send the patients for the genetic panel. So we don't start with the genetics, because obviously some methodologies are not perfect, and you may have a mutation in the gene, but it may not mean that you have tumor that can be related with that. So we leave that last, to be honest with you, because that can confuse patients and cause necessary anxiety.
That's exactly what I had wanted to get, because we have different cascades. Once identified, will ease the method of treatment. That is one. The second question, I saw most of the treatment, the first line was surgery. What in a case wherein you have metastasis, say to the bone, the liver, and then the GI?
Well, then
recommend surgery in that case?
Then depending on your imaging, if they have positive somatostatin receptors, we can give octreotide or lanreotide, and then your options could be chemotherapy or PRT. So obviously surgery is not an option in everybody. We discuss it in MDT and then choose what is the best options for them.
Excellent.
But yeah, it's not always
Excellent. Thank you very much. Thank you very much for the wonderful presentation. Thank you.
We'll now move on to the panel discussion, the much awaited panel discussion. Felix is going to take on from here.
So welcome once again. So Merck Foundation mainly aims to improve access to better diabetes and hypertension care in the underserved communities. So by educating and training medical graduates, Merck Foundation also aims at strengthening local capacities and enhancing clinical management processes And the goal is to raise awareness on these health conditions as well as to support healthcare systems so as to prevent, diagnose, and manage them effectively. So Merck Foundation Nationwide Diabetes and Hypertension Blueprint Program, in partnership with African First Ladies, Ministries of Health, and academia, aim to improve access to equitable and quality diabetes and hypertension care nationwide in African countries. And doctors from different provinces, counties, or districts of the respective countries are provided this 1-year diploma and 2-year master degree in diabetes, preventative cardiovascular medicine, endocrinology, cardiology, and obesity and weight management for English-speaking countries, and a 3-month master course in diabetes management for English, French, Portuguese, and speaking countries. So after some highly informative lectures, now it's high time to move to panel discussion for this evening, where the topic for panel discussion is going to be impacts of Merck Foundation Nationwide Diabetes and Hypertension Blueprint Program by sharing experience as well as successive stories. So we have with us for our panel today, Merck Foundation alumni members who have completed their online program through Merck Foundation Scholarship. So we shall hear the account of impact that their training has had on their practice and communities at large. And each of these panels is going to be given 3 to 5 minutes to complete his or her presentation. So to share their valuable experience on this topic, we have with us today Dr. Caroline Wangui-Mithi, an internal medicine physician from Kenyatta University Teaching, Referral and Research Hospital, and Merck Foundation alumni from Kenya, as well as the next is going to be Dr. Martha N. Joseph, a senior medical officer from Department of Internal Medicine, Katutura Intermediate Hospital, and Merck Foundation alumni in Namibia. Also, we have Dr. Joseph Baluku, a medical officer, special grade at Kirudu National Referral Hospital, and Merck Foundation alumni from Uganda, as well as Dr. Manisha Devi Mohabili Sanj, a senior medical officer, Ministry of Health, and Merck Foundation alumni from Mauritius, and Dr. Om Prakasha Vikari, a consultant at BNB Hospital and Merck Foundation alumni from Nepal, Dr. Heidi Chuatan, Vice Chair, Research Ethics Committee, Medical Panel, University of Cape, Department of Family and Community Medicine, and our Merck Foundation alumni from Philippines, Dr. Sarah Firdausa, an internist, and our Merck Foundation alumni from Indonesia, and I myself, Dr. Felix Foster Mungulu, an internal medicine specialist, and Merck Foundation alumni from Tanzania. So to start, I would like to welcome Dr. Caroline Wangui-Mithi, who is an internal medicine physician from Kenyatta University Teaching and Referral and Research Hospital, and our Merck Foundation alumni. Is a specialist endocrinologist. Dr. Mithi will tell us about the endocrinology clinic started by her and how it is helping her and the community at large. Welcome, Doctor.
Thank you, Dr. Felix. I guess we are all eager to go home, so we'll be 3 minutes. Yeah, so the impact of the training, definitely we are there for getting the knowledge, so it equipped us with the knowledge to become an endocrinologist and diabetologist. And subsequent to that, then I managed to set up. So Kenyatta University Teaching and Referral Hospital has been running for around 3 years. It's a 650-bed capacity. You'll probably see that here. It's a big hospital, one of the referral hospitals. And so there was no endocrinologist, diabetologist at the time. And so having to undergo the training, then I came up and set the hospital, and that on your right side, that's the clinic space. It's a pretty modern hospital, I have to say. So what's the patient impact? So our clinic has been running over 1 year, slightly over 1 year. We've seen over 3,000 patients in the clinic. Basically, these patients had to go into Nairobi, capital city, so probably 30 kilometers to probably see Prof. Otieno in our largest Kenyatta National Hospital, which was our largest referral hospital. And so this really brought services closer to the patients, especially for the central part of Kenya and also that region. It also offer, or rather we also offer a comprehensive diabetes care. And basically what we do is it's a one-stop shop, or everything under one roof, where we have the consultation by myself and my fellow endocrinologist. We have diabetic educated nurses who teach them. Then we have nutritional counseling, and we have the medication therapeutics management. So all in one clinic space, so they won't have to go to different places. Community impact. So we've offered diabetic screening. So the Africa, actually, for most people who know that a third of patients with diabetes are actually undiagnosed. And so we've been offering these community services in terms of screening, giving education and wellness talks, and as I've said, bringing the services closer to the patients. And also this has had a major positive impact on cost and time. So basically, was it successful? I think we have given the impact, or we have brought the impact to the patients by bringing services closer to the people and also to our community. And so we're thankful to the Merck Foundation for this. Thank you.
So next, as I said, is Dr. Martha Joseph, a senior medical officer from Department of Internal Medicine, Katutura Hospital, and our Merck Foundation alumni from Namibia. She will discuss about the endocrinology clinic she opened following her completion in Merck Foundation training, the service offered, and how they're impacting patient lives. She'd also talk about her academic and policy engagement and the role of Merck Foundation in it. Welcome.
Thank you. Good afternoon, everyone. So I'm just going to give you a brief overview of what Merck has done in Namibia. So I started the postgraduate diploma with Merck Foundation in 2020. And during that time, the status quo of the country was that there's no endocrinologist. At the moment, there's still no endocrinologist. A lot of patients were only being seen in the general outpatient department. So we're having a lot of patients that were lost to follow-up. And we didn't have any standardized guidelines in terms of treating common endocrine disorders. So this is my country. It's in southern part of Africa. It's a very beautiful country. And this is my hospital. This is Intermediate Katutura Hospital. It's activating as both a district hospital as well as an intermediate hospital. We have a catchment population of about 500,000, which is quite overwhelming for a country of 2 million people. So ironically, Katutura actually means that a place where we do not want to settle. So a lot of patients also do not want to stay in our facility, but we are always happy to help. So when we set up the specialized clinic, what did we do? Our approach was to start it anyway. We looked at the low-hanging fruit, and in fact, not only the low-hanging fruit, we actually looked at the fruit, or we plucked the fruit that has already fallen on the ground. Most of the hospitals already have laboratories that are doing thyroid function tests, and they have patients with thyroid disorders. So that's where we started. And after that, we grew the clinic gradually, where we are seeing 20 to 30 patients weekly. So we only have a weekly clinic. Of course, we had systemic failures, such as a poor referral system, out of stock medication and radioiodine therapy. But one thing we had was a good nuclear medicine department. And note that I did not say excellent, I said good, with committed people, although we still have issues with systemic failure. So we've really provided a standardized treatment for our patient. We're busy formulating guidelines to just standardize patient. And we have a focal doctor for which patients follow up, so that we eliminate the problem of losing patients to follow up. So we also know that we don't have any data that has been published with regards to diabetes mellitus and its complications. So we're definitely looking into doing more research with the help, obviously, of Merck, because I'm now embarking on my master's course that started in October. So you can imagine the stress when I get back to Namibia. I have to post on Moodle. So in general, this has really been helpful for us, for me particularly, because now I'm a part-time lecturer for the University of Namibia, where I did my undergrad yes, undergrad basically, and I focus on teaching endocrine diseases, and I'm also now a senior medical officer after 2 years in the department. So I'm very grateful for Merck. I'm really grateful that they've heard the cry of my nation, and I hope that they'll sponsor more students from my country.
Now let's call upon Dr. Joseph Baluku, a medical officer grade from Kirudu National Referral Hospital, also a Merck Foundation alumni from Uganda. Dr. Baluku will discuss his clinical and research endeavor in cardiopulmonary medicine, particularly TB. He'll also speak on how Merck Foundation training helped him excel clinically and as well as a researcher.
Good afternoon. So about 8 years ago, I remember I was walking the walkway of my medical school, and I came across this pull-up from Merck Foundation, and it was advertising a contest. And the contest was to write a concept for what a healthy heart needs. I must admit that I hurriedly slapped up a concept and submitted on the very last day. But out of 500 submissions, I was chosen among the 10 lucky ones. And thereafter, I was enrolled onto the postgraduate diploma in preventative cardiovascular medicine. And the course was so meticulously designed that it helps you get the information, but also reflect on the learning. And so it's a very engaging course, and I'm sure most of you are taking it and enjoying it. I also had the opportunity thereafter to take the master's program, and I was lucky to pass with distinction. And the results have been that thereafter I was invited to be a tutor with Lana, which is the platform that offers the courses. And that's a role I play up today. And it's been really, really interesting passing on this knowledge to the other people. Now, I used these credentials to apply for a research career grant with the Royal Society of Tropical Medicine. And when I did that, the goal was to study the burden of cardiovascular disease among people with TB in 4 regions of Uganda. And we found that almost 90% of those individuals had at least one cardiovascular risk factor. And this was interesting to me because I'm so intrigued by the interaction between cardiovascular disease and infectious diseases. Now, that's not all. I used the same credentials and I applied for a research grant from the Fogarty International Center, which is a subsidiary of the National Institute of Health. And this additional grant helped me study, and I'm still currently undertaking the study, 400 TB survivors to see whether indeed TB changes someone's cardiovascular profile. And the data we are seeing that indeed people who survive TB have an altered cardiometabolic profile. The outcome has been 4 peer-reviewed journal publications. I have only mentioned 2 there, including one where we collected data from 110 articles from Africa. And we found that the burden of cardiovascular risk factors is so high among people with active TB. And this explains why many TB survivors, the leading cause of death is cardiovascular disease. I have personally decided to integrate cardiovascular risk scoring and screening for all the TB patients because I love this interaction between TB and cardiovascular disease. And this very coming year, we are going to start a TB survivors clinic at our hospital. Our purpose is to do surveillance for cardiovascular disease in these individuals. And I can tell you, I'm grateful to Merck Foundation for having made me a good teacher, an excellent researcher, and I hope and I feel I'm a better clinician. Thank you very much, Merck Foundation, for taking a chance on me.
Okay, welcome Dr. Manisha Devi Mohabil Shasanj, the Senior Medical Officer, Minister of Health and Merck Foundation alumni from Mauritius. Having worked across a breadth of different specialties and professional roles in Mauritius, she will discuss some of our prominent challenges relevant to diabetes care in our country and how Merck Foundation training prepared her to tackle them and the significance of preventive care in relationship to cardiac conditions. Welcome, Dr. Manisha.
Thank you. Good evening, everyone. I am Dr. Manisha Mohabir from the beautiful Paradise Island of Mauritius. I have been awarded the postgraduate diploma in cardiopreventive medicine in 2021. And after completing it successfully, I have been granted the master's degree in cardiopreventive medicine, which I have just completed in August 2023. So this course has indeed broadened my understanding of cardiovascular disease. As a senior medical health officer, I wish that diabetes, hypertension, and dyslipidemia, as well as cardiovascular disease, be prioritized in my country. The last NCD survey conducted in 2021 showed around 20% of the overall population in Mauritius has diabetes. The prevalence of uncontrolled diabetes is a real concern as it increases the risk of severe health complications such as heart diseases, renal impairment, eye problems, and damaged arteries. The prediabetes and obesity are major precursors of diabetes and cardiovascular disease. Therefore, promoting a healthy lifestyle at an early age will definitely be helpful to reverse this situation. In Mauritius, there are many people living with type 2 diabetes and is ranked 8th in the world, according to the latest WHO data published in 2020. On the other hand, cardiovascular diseases have been the third largest killer in my country among the age group 40 to 65 years old. More than 3,000 deaths were due to heart diseases in 2019, while 19,500 patients were admitted in the different cardiology departments of the regional hospitals for the cardiac treatment. In addition, 4,790 angiographies and 997 cardiac surgeries were conducted. During this course, I gained knowledge on the current practices in hypertension, hypercholesterolemia management worldwide, as well as the latest and upcoming treatment. In tackling the growing epidemics of hypertension and cardiovascular disease as risk factor in Mauritius, there is an urgent need for current evidence-based and population-focused guidance on managing hypertension. I plan to continue being an advocate for cardiovascular disease prevention in Mauritius through promoting the primary prevention of cardiovascular disease in terms of healthy lifestyle, for example, exercise, diet management, smoking cessation programs, setting up wellness clinics that offer routine assessments to ensure early diagnosis and intervention. The impact of this master degree will definitely help in improving cardiovascular disease care in Mauritius. It will help advocating for equitable cardiovascular disease through the access to better medicine and services for the cardiovascular disease-related conditions. As Mauritius is striving for a universal health coverage and improving primary health care services, I think that my course will definitely be an asset to my country. The clinicians that are strategically positioned to reverse the perception of cardiovascular disease will be a helping hand in taking a backstage in prioritizing this clinical aspect, increasing human capacity for tackling NCDs at the policy and healthcare levels will help in managing this field. And investing in human capacity through the funding from Merck Foundation will give boost and enable for more hands to be available in the detection and management and managing cardiovascular disease. I thank you, Merck Foundation, for giving me this platform, and I hope I will be a role model for other Mauritians to come and be an advocate for cardio-preventive medicine. And I hope the government of Mauritius will try to set up a new clinic for prevention, for preventative cardiovascular disease. I hope. Thank you.
I'd like to welcome Dr. Hedi Chuatan, a Vice Chair, Research Ethics Committee at Medical Panel University of Cebu, from Department of Family and Community Medicine and Merck Foundation alumni from Philippines. She will speak on challenges in diabetes and endocrinology care in our country, how she aspires to improve this as an endocrinologist trained by Merck Foundation, and our clinical research and administrative endeavors. Welcome, Doctor.
Hello, good evening, everyone. We've had a long day. We've had a long day. Now I'm here to tell a story of how I've heard of Merck. Oh, how I came about in India. So it is a story of first times. It is the first time that I am here on an international travel alone. It is my first time here in India, and 2 years ago, it was the first time that I heard about Merck Foundation. It started when the pandemic, I had to close 2 of my private clinics. The out-of-pocket expenses became too much. So we had to close the private clinics, and I was offered to serve the government hospital as a medical officer. So as a medical officer, I was thrust to community service. So then the next month, I was diagnosed with papillary thyroid carcinoma. I had surgery, and then I heard of Merck. Then I applied for a scholarship, and I was thankfully granted the scholarship, and I was told to enroll to a postgraduate diabetes endocrinology course with Queen Mary University of London. And then I get pregnant during the course. And you know, when we are pregnant, all we want to do is sleep. So it was very hard. And with the time difference from London and Philippines, I had to take the course in the evenings, about 6 p.m. and beyond. So it was quite a challenge being pregnant. And then we had Typhoon Rai. It disrupted our water supply and electricity for about 2 months. So I wasn't able to attend synchronous modules with the course. But then I was able to catch up. And then I had cesarean section, and I had another cancer scare. It was a BIRADS 4 breast mass. Thankfully, when we did biopsy, it turned out to be benign. So now I finally took the final exam this year, January, and I just received my final certificate 3 months ago. So I'm very thankful to be here. So as a family medicine, I am a primary care provider now with the marginalized and indigent population because I was thrust into the government hospital. The COVID pandemic lockdowns, when I first went on duty at the government hospital, what I noted was there was an increased number of diabetic foot that needed to be amputated. Apparently, the lockdowns, the restrictions, and the fear and the unemployment, our diabetic patients have been left unmonitored and thus wallowing in complications of diabetes, leading to limb amputations. And these were our population that needed to be healthy for employment, for income generation. So limb amputation really affected their quality of life and the quality of life of their families. So thankfully, with Merck Foundation, I've been enriched with proficiency in diabetes and endocrinology, and hopefully we can contribute significantly, as I am also a trainer in residency training programs, actually 3 residency training programs in our community in Cebu, Philippines. So I can teach the residents to how to manage and monitor our patients with diabetes. And we are planning to launch a community-oriented program that would address primary care and monitoring despite limited resources. So, and I am also a teacher, and I'm also a teacher in a medical school. So I am sharing the knowledge that I had and teaching strategies that I gained from online distance learning with Queen Mary University of London. I'm starting to incorporate it in my teaching strategies in medical school. So currently, this is what I do, but the most impact I had, especially for the past 2 days, was seeing our Senator Rajesh and also our first ladies, how strong women are able to impact community. So hopefully with this opportunity Merck Foundation Incorporated has given us, we would impact our communities and better healthcare services in each one of our regions. Thank you very much, everyone.
Okay, now I'd like to call upon Dr. Sarah Firdausa, internist and our Merck Foundation alumni from Indonesia. As an active clinician and researcher, she'll speak on the contribution of Merck Foundation training in furthering her career, including her research and academic engagement. Welcome, Dr. Sarah.
Hello. Thank you so much for the moderator. The slide, please. Thank you so much. Okay, ladies and gentlemen, good evening. It's come to my opportunity. Thank you for giving me opportunity to share my experiences and success stories on Merck Foundation journey. I was a postgraduate diploma student last year and currently as an MSc student also in endocrinology. As you know, as we know that we all face the challenges and also we have to overcome all the challenges. As I mentioned here some, such as lack of knowledge, lack of confidence, increased disease prevalences, limited facilities, and also community burden. But by joining Merck Foundation training that I had last year, I gained a lot of knowledge, enlightenment, and also by gain more knowledge, I will have more confidence. And with these two models, and then I have a power to prevent the disease by enhance my community to prevent any diseases. The way I overcome the limited facilities, I usually collaborate with other institutions, whether they can share facilities or they can share opinion or instruction regarding diagnosis and treatment. And we propose some proposal to make a campaign to the community. You know that I live in small town in Aceh. Many community in our city used to like to use herb or alternative medicine. So I have more power, I have more knowledge to educate them not to use herb or alternative medicine frequently. And this is how Merck Foundation training has enhanced my practice. I have told you that I gain more knowledge on my field in endocrinology, and I make my practice to involve with decision or intervention based on medical evidence. And now I have an opportunity to connect with you all, my colleagues, my peers, and also with a great teacher, great tutor, and many experts from various field. And also I was so blessed with my tutor during my last year postgraduate training. And in this current time, I also has conduct a systematic review as a part of research skill in an MSc Module 2 platform. So I have gained more knowledge on how to conduct research and how to publish the result of research appropriately. And I also have involved in educational role. As you can see, I have an active member of some professional organizations such as Endocrine Society and also the IRCS and also the Endocrine Society or professional organization in my national country. I involve myself to teaching and learning process, and this is one of picture when I teach my internal medicine specialist. And thank you to Merck Foundation. In the last 2 weeks, I just received my certificate with the result of distinction. Thank you so much. This is my last slide. I was engaged in several even to be a speaker. And last 2 months, I just received a presenter award for my abstract. And if you want to see some of my publication, you can go to my Google Scholar profile. There were some of endocrine manuscript that has been published recently. And this is my my endocrine team in Aceh. Dr. Krishna is the oldest one, is the founding father of endocrine clinic in Aceh. Dr. Hendra is an expert in thyroid. Dr. Tia is my colleagues. Dr. Molina is my colleague, and this is me when I was pregnant for the first time after 13 years married. Thank you so much for your attention.
Very good afternoon. You must be very tired, and
so now, welcome, Dr. Om.
Thank you. Thank you. So I'm going to summarize what my previous colleagues said. This is all the summary. The message is, I think, the same. And I'm internal medicine physician working in Kathmandu from Nepal. I've been working in this field for last 2 decades. Fortunately, I came in contact with the Merck Foundation 2 years ago. I applied for PG diploma in diabetes. After successfully completing that, I joined MSc, and a couple of months ago, I completed my MSc from the University of South Wales. So I'm talking a little bit about impact of this course. This course is excellent, I think, excellent to elevate the learning experience in a doctor, in a healthcare professional. So knowledge is enriched and skills are further improvised, and leading to the confidence to treat more complicated cases. And that confidence we can transfer to our patients, so patient will feel more confident, and as a result, their patient adherence will be improved. So they will definitely say that my doctor is capable, my doctor is knowledgeable, skillful. So indirectly, it is helping me. That is what I have experienced after the course. The diabetes, MSc and postgraduate diploma in diabetes, they changed my perspective to diabetes. I've been practicing for last 2 decades in the field of medicine, but after taking this course, my perspective on diabetes care totally changed. And I started discovering very new things, and every strange things in diabetes care. So I'm very thankful to the Merck Foundation for providing me this extraordinary and excellent opportunity. Overall, there is more better patient care in terms of good glycemic control and timely detection of the diabetes related complications and improved quality of life of the patients. These things I felt after this course. Yes, there are few obstacles, there are few hurdles in the management of diabetes, especially in resource poor countries. Number one is there is no uniformity of the uniformity in the expertise and expertise of the healthcare professionals. They have been trained in different centers with different types of the different schools. So there is lack of uniformity. So there is point we should improvise, and practice is basically the drug-centered practice. We bombard with drugs, but we often forget to focus or to address the lifestyle interventions like diet and exercise and the psychological aspect of the patients. So this is very prevalent. This is prevalent practice, and which is degrading the diabetes care in the community or in the treatment sector. So I after passing this course, I strongly advocate the subsidized treatment for poor people, and I advocate for training to the district level medical graduates, especially who are working in government sector, and setting up diabetes referral centers from the government level, not the private levels. So those three things can really uplift the service of diabetes to the people of Nepal. So that was what I feel. Evidence-based medicine. I was asked to talk about something about evidence-based medicine, but this is lagging, grossly lagging. Evidence is on one side, practice is in other side. So there is a lot of gap between evidence-based medicine and real-world practice in our setup. So I think we can improve this evidence-based practice. We can apply this evidence-based practice by educating the stakeholders to make them participating in the treatment process and planning process. So that will improve the diabetes care in ultimately improve the diabetes care. So, but last not the least, I want to thank Merck Foundation, especially the nationwide Diabetes and Hypertension Blue Points program, for providing me the great opportunity, great learning opportunity, the PG diploma, MSc in diabetes. And I heartily thanks to the organizer of this program, this mega event, and providing me opportunity to share my thoughts and feelings in the forum. And thanks to all the panelists and all the listeners. I'm sorry about the long talk. Thank you so much.
Okay, once again, as I've been introduced earlier, my name is Dr. Felix Fausto Mungulu, an internal medicine specialist and Merck Foundation alumni from Tanzania. As an internal medicine specialist, I would like to speak on how Merck Foundation training has influenced my clinical approach. And also I will speak on sectors that are most in need of attention in terms of patient care and research at my community. So specialized clinical training in need at my community are mainly reproductive endocrinology, diabetology, cardiology, nephrology, diabetic foot disorders, endocrinology, as well as obesity and weight management. Following completion my program, this has helped me to consolidate my practical knowledge of endocrinology and understand the global perspective of endocrinology conditions toward achieving my goal of becoming an expert and qualified physician who understands really clinical sciences relevant to endocrinology and perform evidence-based practice as an endocrinologist. And also this has helped me to grow professionally, helped me accomplish my dream of increasing patient education and awareness regarding endocrinology conditions. Again, this has enabled me to develop enough skills which are sufficient enough to manage endocrine-related conditions, and hence have an impact on reducing morbidity and mortality related to endocrine diseases in my country. And it has enabled me to share the knowledge acquired from the courses with my fellow medical practitioners at the hospital where I'm working, and teach junior staff and medical students how to have a good teamwork in dealing with conditions related to endocrine disorders. So currently I'm working in the internal medicine department at endocrinology unit in Muhimbili National Hospital, where I oversee patients admitted to the wards with endocrinology conditions, and we usually conduct endocrinology and diabetes clinic from Monday to Friday. As part of research interest, I published an article in a peer-reviewed journal of mineral bone disorders as part of an endocrinology condition among patients with chronic kidney disease. Thank you for listening.
Thank you, Felix. Thank you all our esteemed panelists here. Would like to remind you of the Merck Foundation application, which is readily available on Google Store as well as Apple Store. You can now receive timely updates on our various courses as well as other initiatives through the application. Please do download it at your earliest convenience. We would like to conclude this session with a vote of thanks to all our speakers, all our panelists, moderators, and attendees in joining us in making this a resounding success. Thank you so much. We look forward to seeing you all very soon for more knowledge exchange and learning opportunities. Thank you, everyone. Please be safe and have a great day ahead. I hope everybody has received their certificates. If not, we could please collect it from my colleague here.